Good morning, everyone, and welcome to the second day of the Master Clinical course for the ST3 TNO training. Welcome Ahmed Ashur and Ahmed Tal Ashur for today. We'll be starting on time, so give it 1 minute, then we'll restart.
Can you see my screen, Hashim?
Yeah, we do. Just make it slideshow.
Yeah.
Okay, Ahmed, I think you can start.
Hi, good morning, everyone. My name is Ahmed. I'm going today to present two topics, general guidelines and X-ray interpretation. So first of all, why this topic matters? Because first impression lasts. So they will ask you first question, how do you comment on the X-ray or CT or photo or whatever? So if they heard a good comment, they will be interested the whole station. Having a mental toolbox and up-to-date guidelines, having a systemic approach make you show that you're ready to be a day one registrar. This presentation aim to summarize key guidelines. I'm not going to mention every guidelines, but I'm going to give you key guidelines, the important ones. And also I'm going to give you a technique how to present an X-ray. My technique. So guidelines, know your poster guidelines. I think you have to know every poster guideline by heart. You're not allowed to not know any poster guideline. I'll not go into details. They are free there, but make sure that to check them. They are updated every day. I think there are a couple of them at 2025 updated. So make sure you know every poster guideline by heart. Neck of femur, make sure that you know the best practice tariff guidelines. And also, and also the NICE guidelines for total hip replacements, the 4 criteria. In an open fracture, make sure to know the poster guideline, the ATLS principles, difference between DCO and early appropriate care, and crash through 2 trial about the tranexamic acid. Coda equina, have a read about the BASS guidelines. NICE guidelines, there is a NICE guidelines for low back pain, and also poster guideline for spinal emergencies. Ankle poster guidelines, distal radius and scaphoid, you know, the draft study, and also the NICE guidelines for non-complex fractures. Septic arthritis in a child, make sure you know the modified Cocker's criteria. There are NICE guidelines for septic arthritis, and there are poster guidelines for musculoskeletal infection. Necrotizing fasciitis. So I have a read about some paper called the C1 paper. So it summarize how to approach, surgically, how to do the debridement in a neck patch patient. And then compartment syndrome, poster guidelines, tendons, anything about tendons and hand, there are PSSH guidelines, which in summary say that flexor and extender should be repaired within 4 days. If it's closed hand fracture, within 7 days, and 72 hours if it's or 72 hours if conservative management fails. So this is the first part of my topic. And then the second one will be how to interpret an X-ray. You should have a systematic framework. In general rule, APCS. This is a general framework. A for adequacy, B for bone, C for cartilage, and S for soft tissue. You might not have the time to comment on APCS. I will show you my technique. So in general, describe the X-ray first before you jump to the spot diagnosis. So you have to show what you see before going to the spot diagnosis. Always check the details, skeletal maturity, orientation, dates, in general demographics. If you have one view, make sure to mention, I want other view. If you have an X-ray and you want further imaging like CT, do it, say it in the first question. If the X-ray is suboptimal or remain not very clear, you can mention this. My technique will be 3 steps. First of all, present this is an opening statement. You can say it in every patient. So this is an AP radiograph. For example, this is an AP radiograph of the right hip in a skeletally mature patient with unknown demographics. This can apply in any X-ray. And if it's an MRI scan or CT scan, you have to decide whether this is a T1 or T2 and whether this is what type of cut, sagittal, coronal, or axial. Step 2, you have to describe what are you seeing in X-ray. So for example, in a distal radius fracture, comment on the shortening, angulation, displacement, comminution, and ulnar fracture or not. Also, for example, in a carpus bone, any carpus fracture like scaphoid or perilinate dislocation, comment on the gilulus line, assessment of the signs, which is assigned to assess the carpal instability, assess if there is any radiolucency of the scaphoid or suggest a location of the periosteal reaction. So in general, describe it first before you jump to the diagnosis. And then step 3, diagnosis, and you can mention classification if you can. It's not mandatory, but if you can, move you from 4 to 5. So for example, this is a Mayfield 3 perilinate dislocation, or this is a Gartland 1 supracondylar humerus fracture. I will give you an example. How did I approach the X-ray? And then I will ask 5 volunteers to comment. I will give them a feedback. So for example, this is a PA and lateral radiograph centered over the right wrist in a skeletally mature patient with no demographics, showing disruption of gilulus line, widening of the scapholinate interval, and dorsal dislocation of the carpal bones compared to the lunates. So this is a Mayfield 3 perilinate dislocation. If you see, guys, it's less than 1 minute, until I said everything about the case. They will know that you know what they're going to ask you. This is a 5 out of 5 marking. So I hope everyone can learn this technique. Okay, so next will be, I will need a volunteer. If anyone wants to volunteer, I will just raise your hand, please. I have five X-rays.
Yeah, I can do it. Yeah.
Yeah, go for it.
Okay, so this is a lateral radiograph of skeletally mature individual. What I can see, there is a displaced olecranon fracture. I can't see any other fractures, but I'm more worried about the coronoid process. I'll need other radiographs. This is mostly non-comminuted olecranon fracture.
Okay, well done. Quick tip, sorry, I didn't say it. Take few seconds before you jump to the comment. So you can take up to 10, 20, 30 seconds. Make it up in your mind and then say it in a one neat way.
Okay.
You described everything, but make sure to mention this is an elbow. You didn't mention anything about an elbow.
Okay.
And also then say about I'm worried or concerned about a fracture. Don't dig a hole to yourself. So there is no just don't mention it. Yeah, this is a displaced no comminution. So you describe the X-ray. Yeah, well done. Who's gonna go next? And also, sorry, before we go, you can mention something about soft tissue swelling around it. So this could be a hematoma around the fracture sites.
Yeah, thank you.
Yeah. Who's gonna go next?
Hey, King.
Yeah, go for it.
So it's a plain radiograph showing a lateral view of an elbow, the most obvious pathology, a posterior elbow dislocation. I would like this patient should be treated based on the ATLS protocol, trying to reduce the elbow, and they will require further imaging after that.
Okay. Well done. First of all, when you describe an X-ray, you said it's posterior. If you look at the AB, there is a lateral element of dislocation. So this is a posterolateral. Well done in identify this is a posterior. 2, you have to comment in or if there is any fractures or not. So this is part of the description of the X-ray. So you can mention, I cannot appreciate fractures, but if you're suspecting a fracture, I would like to reduce it and request a CT post-reduction. 3, don't comment on the ATLS, wait for them to ask the question. So they ask you one question, answer it. Yeah? Done?
That's great, thank you.
Who's gonna go next?
Yeah, I can go.
All right, Mohammed, go for it.
Yeah, this is an AP and lateral radiograph of an elbow. There's showing there's an evidence of fracture of the supracondylar supracondylar fracture. Most probably it will be Gartner 3 or 4. There's no evidence of fractures of the radial head. I would like to assess this patient for this injury for any other vascular injuries.
Okay. Well done. You described everything. You can put more description on the fracture itself. So if you compare the proximal and distal ends of the fracture, you can say there is an element of rotation. Also, you can describe the anterior and posterior humeral lines. This is part of the description. Also, you can describe disruption of the Bowman's angle, which is a coronal deformity. Have a read about it. But otherwise, also, sorry, one comment, say if this flexion or extension, right? This is an important. Yeah.
Okay,
Good job.
thank you.
Who's gonna go next?
I can do it.
Yeah. Go, Mohammed. Sorry, quite hard one.
Yeah. So this is a BA X-ray of skeletal mature right hip with a known demography, which show disruption in the integrity in right subtrochanteric area. The fracture themselves is minimal displaced. I could appreciate there is radiolucent area in subtrochanteric area, and there is also thickness in the lateral wall in the proximal femur. Most probably, I would appreciate to have a lateral view of this hip, and this is most probably pathological fracture. With given the nature of thickness of the lateral wall, I would suggest that it might be bisphosphonate type of subtrochanteric right femur.
Okay, I think you spent 2 minutes or something. This is too long. I know it's a difficult one. I know you wanted to mention everything, but they just wanted an excellent option. Okay. Couple of comments. You said it's minimally displaced. No, this is a displaced one. You can describe more about the fractures. So you can say this is a transverse fracture with a varus deformity. This is a language. Yeah. So if they heard this, they know you have been seeing this before. You have been in a call before. Yeah. You can describe more of the lesion. So this is a lytic lesion. They're well defined, narrow zone of transition. All of this are more description of the lesion. So this is an X-ray of both a fracture and a lytic lesion. So you can describe both. Yeah. And at the end, don't say it's a bisphosphonate. You don't know. So there is a lytic lesion. You don't know what's this. Yep. It could be a bisphosphonate, but don't say it at the beginning. Yep. Good job.
Thank you.
And you said about the lateral, right? You said,
Yeah,
I would like to have a lateral X-ray. Okay.
Yeah.
All right. Who wanna go finally? I think only one left.
Can I go, please?
Yeah, go for it.
So this is a radiograph, AP radiograph for pelvis showing evidence of anterior dislocation of the left hip. However, I will request another orthogonal view, including the lateral view of the left hip to assess the direction of the
Okay.
dislocation. I cannot see any other fractures on the radiograph. My concern is high energy trauma, so I will assess the patient according to the ATLS protocol, neurovascular status, and the scan as well, and compartment syndrome.
Okay. Good job. So you described everything, but if I were you, I will describe the X-ray first itself. So before saying this is an anterior dislocation, so I would say there is a disruption of the femoroacetabular joints. This is an anterior hip dislocation, and also you can comment on the catheter. So there is a catheter in situ. Yeah, you did comment on the fractures. Well done. You did request a lateral view. Well done. So I think you did a very good job.
Yep.
All right. Thank you, everyone. Sorry, it was a brief presentation. I was post-night, so I hope it was useful. Thank you.
Thank you so much, Ahmad Ashur, for doing such a nice presentation after your night on call. Yeah, we really appreciate it. So go have some rest. And now I think it's Ahmad Tariq Ashur. So
Hello, everyone. Good morning. Hope you're doing all right.
so guys, so I think like the first couple of topics, X-ray interpretation and guidelines. Yeah, it's not a big topic. That's why it's just like we're running ahead of time, which is good, better than yesterday. Also, the presentation was very nice. I will ask Ahmad Ashur just to share it with you guys so you can have a look at which guidelines, which like big study papers to mention in which stations, which is really nice. I'll leave you now for the big boss, Ahmad Tariq Ashur. Yeah, just worth mentioning, Ahmad Tariq Ashur got his job after just 7 months working in UK. So there is always hope for everything, guys. So he's a role model for how quick you can get an ST3 job after being in a different country.
Thank you. Can you see my screen?
Yeah, we do.
All right, that's fine. So today I'll speak about some upper limb topics, basically on the shoulder. I'll ask you guys to present first the X-ray, and then we go through some questions together. So how to score in the interview? So you have to get a structure. So all the questions are answered in a similar way. So you have to practice and develop a way so that the moment they ask you these questions, you don't think about it. You just have a spiel about everything and say it smoothly. And then you can focus on the difficult questions they're going to ask you. So lead with your structure, see what you're saying on the X-ray, say your examination, how you're going to assess your patient. Try to signpost everything, which I found really important. Important to mention the documentation. So don't just mention you're going to examine the neurological exam, just say you're going to document that as well. Link to the anatomy. If you're saying I want to examine his neurology, just be extra specific and say what exactly do you want to examine. In a hip dislocation, say it's sciatic nerve. In a shoulder, say it's axillary nerve. Just be more specific. Use the safe surgeon language. Always check the ATLS. Just get it out of your mouth. Open injury, skin compromise, polytrauma. So your default spiel, should you describe your X-ray as my colleague have mentioned, say this is an AP or lateral radiograph of unknown demographics of a skeletal mature individual showing the right shoulder. The most obvious finding I can see is that, and then rule out fractures, soft tissue, and others. Following that, mention immediately your immediate concern. So after you're saying your X-ray, I'm immediately concerned about a vascular injury. I'm immediately concerned about AVN, about infection. Spell it out early on. And then get your one line ATLS. I'll examine, this is a high energy trauma. I'll examine this patient by doing a primary survey to rule out life or limb threatening injuries, followed by a secondary survey to make sure it's isolated, closed, and neurovascular injury. You have to practice this by heart so you don't think about it. Then assess the patient. I'll try to signpost it in every case. So I'm going to assess this patient clinically, radiologically, and biochemically. Clinically, so history and examination. And then radiologically, if you need any further imaging, X-rays or CT. And then biochemistry, you'll take bloods, infection markers, whatever. In the history, say I'll take ample history, allergies, medical history, past medical history, when the last patient ate, and the events that led to the injury itself. In the upper limb specifically, try to ask about hand dominance, occupation, and social history. Then you'll examine the neurovascular structure, and as I've mentioned, try to mention what neurovascular structure exactly are you looking for, and then split up your management into immediate management and definite management. So immediate management is always going to be analgesia and ED, immobilize in a back slab or splint, consent for the operation, and then your definitive management, which will be whether to have an operation or no. So our first patient here is a 24 years old male, had a high speed road traffic accident with the shoulder, left severe shoulder pain.
The screen is not moving, so you're still on the title screen.
Oh, really? Okay. What's happening here?
So I think you have the second slide about scoring in the interview. So
All right. No idea what's happening
yeah,
here.
that's now on. Yeah, if you make it slide share, it'll be clear.
What's a slideshow?
No, go from down. It's different. I think it's only.
Yeah.
Yeah. No, this will make it bigger.
Yeah, here maybe. Can you see now?
Yeah, we see it, but we see all the slides.
Sorry about that, guys. So I'll stop sharing and share back again. Maybe it gets.
Don't worry. No, there is a slideshow up there. If you go the highest menu, just under.
Yeah,
Go up
I click on slideshow and
No. The slideshow is no, it's not that. Just on the right side, not insert. Go up.
yeah,
Just in the middle in the screen here.
just a minute.
There. No. There. Yeah. Where are you? Just one side, yeah. The slideshow, yeah. Review, view, slide share. No, in the main screen here.
Just a minute. But
It's in the toolbar. Yeah.
let me just stop sharing and do it from the start. Can you see now?
Yeah, perfect. Yeah.
All right. So yeah, sorry about that. So 24 years, high energy trauma with right shoulder pain. Can someone comment on this X-ray, please?
Yeah, I can try.
Yeah.
So this is AP and lateral wise view of the left shoulder of skeletally mature individual. The most striking finding I can see is disruption of the glenohumeral joint with the humerus inferior and anterior to the glenoid cavity. So my finding is anterior dislocation of the left shoulder. I can't see any other fractures, but I can't rule out I will need repeat X-rays after the reduction maneuver.
Okay, that's really good. So a couple of extra things you can say to show off. So you can get a full, so this is an inadequate X-ray because you can't see the chest or the port of the clavicle. So ideally, I would need an adequate X-ray. And the other thing just to show off, there's a small Hill-Sachs lesion here in the posterolateral aspect of the humerus. So I can mention, I can appreciate a Hill-Sachs lesion. And then my key concern here is dislocated joint and neurovascular injury. Good. So, sorry, before that. So this station is mainly about the brachial plexus. Um, can anyone tell me about the brachial plexus? The roots, trunks, and divisions, just in a couple of short lines. No? All right, I know it's a tricky topic, so I'll just go straight through it. So the brachial plexus is formed by roots, trunks, division, cords, and terminal branches. This picture is really important. It came out a couple of years ago. So you've got the C5 and C6, they form the upper trunk, C7, middle trunk, C8 and T1, the lower trunk, and then they get their branches, the musculoskeletal, axillary, radial, and ulnar. So they're formed by the rami of C7 to 8 to T8 to 8-1, and then the suprascapular nerve, the nerve subclavius exits the superior trunk. Each trunk divides in anterior and posterior divisions, and the posterior divisions form the posterior cord. So it's mainly important in getting the image right and knowing what each main branch, the median and radial ulnar nerve, the root value. It's just you have to go through it and read it. And I know it's a tough topic. I always forget it after I study it, but it's really important. So now, the next question is, this patient cannot abduct his shoulder after dislocation. What nerve could be injured here and how do you test it? Any volunteers?
Can you go for that?
Yeah.
So the nerve has been injured here is the axillary nerve. That nerve most probably with the cases for the shoulder dislocation would be injured. So I need to check it sensory and motor. Sensory, I will check the sensation in the lower badge area of the shoulder, and motor. I think that will be hard for that patient because patient is having shoulder dislocation. But in motor function, we can test the abduction from 15 to 90 degrees.
Brilliant. And what muscle are you testing when you're testing the abduction?
So between 15 and 90 degrees, that will be the deltoid muscle that's supplied by the axillary nerve.
Anterior fibers of the deltoid, yeah. So the axillary nerve root value is C5 to C6, very high risk of injury in anterior dislocation and surgical neck fractures. Its motor function, as you've mentioned, it's abduction 15 to 90 degrees along with the teres, and it supplies also the teres minor, which is responsible for external rotation. Sensory is over the regimental badge area, over the lateral shoulder. And if following reduction, it's still neuropraxia, managed as proposed guidelines for peripheral nerve injury. And some people, even if you're thinking about a brachial plexus injury, they might do an MRI brachial plexus. Those are some of the injuries that can happen with the brachial plexus as well. So first one is Erb's palsy from the traction of the shoulder. This is the upper trunk C5, C6, and it's the characteristic police step position. So they're adducted, internally rotated, extended elbow, and pronated forearm, waiter step or police step position. And lateral sensation over the lateral arm, the forearm may be reduced. The other one is the Klumpke's palsy. This is C8 to T1 and results in clawing of the hand, affects the muscles of the hand and wrist flexors, and affects the ulnar side of the arm and the forearm. So they're always in extreme hyperextension of the metacarpopharyngeal and the wrist and the flexion of the interpharyngeal joint. So you just have to go through this along with the courses of the radial ulnar and median nerve. I didn't really put them in those presentations because they're just you can read them, find good pictures on the internet. So next question, what stabilizes the glenohumeral joint? Any volunteers?
Yeah,
Guys, you
well,
can say
I
anything.
can.
Yeah, go
I'm happy. Okay.
ahead. Good.
Talking about the stabilizers, we have static stabilizers and dynamic stabilizers. The static would be the congruency between the head of the humerus and the glenoid cavity and the joint capsule and the labrum of the glenoid and the ligaments. The dynamic part would be the muscles, especially the rotator cuff muscles and the deltoid muscle. Yeah, that's it.
Good. So a good tactic is to, yeah, split them as static and dynamic, and then in the static, split them into bony and ligamentous. So in static bony, as you've mentioned, it's the articulation between the glenoid and the humeral head, the negative intra-articular pressure and the version of glenoid itself, and the ligaments or the labrum, inferior glenohumeral ligament, and the capsule. Dynamic are the rotator cuff muscles and the muscles around the shoulder, including the biceps and the scapular stabilizers. Um, Anterior stability, it's just when they are unstable, this is usually because of the bony part, which is the Hill-Sachs lesion, and the ligamentous part, which is the Bankert lesion or the labrum. Next question, rotator cuff, actions, innervations, and clinical tests. Come on,
Yeah, I
guys.
can go.
Yeah.
So the rotator cuffs are we have supraspinatus, infraspinatus, teres minor, subscapularis.
Yeah.
Supraspinatus origin from supraspinous fossa of the scapula. Insertion superior facet of the greater tuberosity.
Yeah.
Innervation by suprascapular nerve. And abduction from 0 to 15. Infraspinatus from the infraspinous fossa, the scapula, in the greater tuberosity as well, in the middle facet. Suprascapular nerve as well, the innervation and the action external rotation. Teres minor from the lateral bulbar of the scapula, inserted in the greater tuberosity as well in the inferior facet. Its action external rotation, and abduction, innervated by the axillary nerve. Subscapularis from the subscapular fossa of the scapula, inserted in the lesser tuberosity, and its action is internal rotation, innervated by lower and upper subscapular nerve.
Do you know any special tests for each of these rotator cuff muscles?
Um, uh,
You know about the Jobs test for the suprascapularis?
yeah, but I know them, but not in
Yeah,
heart. So
fine.
yeah.
Just an extra point, a test for each. So yeah, you've mentioned everything correctly. Just to add on, the supraspinatus, you do the Jobs test or the empty can test. The infraspinatus is the external rotation test. Teres minor is the Hornblower test, and subscap is the Gilbert lift-off test. So this is a good picture as well, showing the rotator cuff muscles. So that's your glenoid fossa. Those are the three muscles. The supraspinatus, infraspinatus, teres minor, and subscap is anterior. Then the pectoralis major. So that's your deltopectoral groove. That's your deltoid, and that's your pectoralis major. And the cephalic vein lies in between. And in the back here is the posterior fibers of the deltoid as well. This is a very good picture as well, and it can come in the exams. One of these questions I hate as well, axillary space and other contents. Any volunteers for that?
Yeah, I can go as well.
Yeah.
So quadrangular space, superior teres minor, inferior teres major, and lateral the humerus, medial long head of triceps. Triangular space, um, triangular space, superior is triangular interval superior is teres major and the lateral and the humerus medial the triceps, and triangular space superior teres minor, inferior teres major, lateral long head of triceps.
And their contents, that's the important
So
bit.
quadrangular is the axillary nerve and posterior circumflex humeral artery. Triangular space scapular circumflex artery, triangular interval profound radial artery, and the profunda radial nerve and profunda brachial artery.
Very good. So yeah, that's a good picture as well. So here's your teres minor. Sorry. Here's your teres minor and here's your teres major. Lateral surgical neck of the humerus and the long head of triceps. The triangular space had the circumflex scapular artery. This is your suprascapular nerve and suprascapular fossa. In the quadrangular space here, you've got your axillary posterior circumflex, and the triangular interval is the radial nerve. It's very important if they got you like a similar picture to that, and also when you're put this picture in your mind, and when you're asked about the course of a nerve, just make sure you mention that like the radial nerve would pass through the triangular interval, axillary nerve would pass through the quadrangular space, etc. Injuries associated with the shoulder dislocation. Yeah, can someone mention any two injuries associated?
I think it's most important with shoulder dislocation to exclude clavicular fracture plus chest injury. I think this is two most common injury with shoulder dislocation plus fracture dislocation.
That's very good. So we have the first associated injuries or the bony injuries. So you've got your heel sacs lesion. So what's heel sacs? It's a posterolateral cortical depression in the head, and it happens mostly during the anterior dislocation. You've got also the reverse heel sacs lesion, which is an anteromedial cortical depression due to impaction of the posterior glenoid. Its counterpart on the glenoid is your Bankert. You can have a bony Bankert or a ligamentous Bankert. Bony Bankert is a fragment of the glenoid breaks in the anterior glenoid labrum. And your reverse Bankert lesion, which is the posterior glenoid labrum, and this is a posterior humeral dislocation. You can have also a tubercle fracture, a lesser tubercle fracture, which is most commonly with the posterior dislocation, a greater tubercle fracture with the anterior dislocation. And then you can have your ligamentous injuries, slap tear, which is very common, and then your neurovascular structures, the axillary nerve, brachial plexus, and vascular injuries. All right, so now with the fun bit. So this is the question mostly you're going to be asked first after being presented with the shoulder dislocation X-ray. So can someone, as we've mentioned in the first slide, try to make it systematic, clinically, radiologically, and biochemically, initial management, and then definitive management, history and everything. Would someone like to give it a try?
Yeah, I can do it. So regarding to its mechanism of action, I would like to assess and manage this patient in AD according to ATLS guideline, assuming this is isolated close injury. I would like to down to assess the patient myself. First of all, I would like to get comprehensive history about mode of injury, about dominant of hand, of course, after taking ample history, which include allergy medication last time of 800 drink, and also after taking a brief history about dominant hand function baseline, I would like to assess the patient clinically. My main concern is the neurovascular status of the limb and the pain threshold. I would like to assess the neurovascular state and document it clearly, especially the regimental patch area for sensory distribution of axillary nerve, medial, radial, anterior interosseous nerve as well. Check the radial pulse and check capillary refilling site. Check the deformity and if the appropriate analgesia and sedation available during the during this episodes. I would like to give one go for sedation and try to reduce this fracture using traction counter traction technique, and if I would succeed to reduce it, I would try like to assess the neurovascular states after reduction and document it, send the patient for X-ray after put him in appropriate sling or collar and cuff. I think this is the initial treatment for this patient, and according to age, there is some study and evidence say that if the patient between 18 and 25, he need to do MRI scan, and as my main concern is the tendency of recurrent shoulder dislocation, which could be minimized by doing MRI scan. If it's old lady, my main concern would be the integrity of rotator cuff, and some evidence suggests to do ultrasound, but it not in acute setting. And after that, after make sure this is patient has appropriate immobilizer, I would refer the patient for physiotherapy, try to see the patient in 1 or 2 weeks in fracture clinic for further assessment the integrity of rotator cuff tear and the stability, and manage accordingly.
Yeah, that's a very, very good answer. It looks like you know your stuff, but you spent like 6, 7 minutes in this. So it really is, I can really see that you know what you're doing, but you need to get into the time constraint you have. So this answer shouldn't take you like a minute and a half most. You can you shouldn't have to say everything in details. And the first bit you took so much time in it, but and that's just will come with practice. So how would I say this? So this patient has got a shoulder dislocation. We have described the X-ray now. So I'll assess this patient clinically, radiologically, and biochemically. Clinically, I'd like to get an ample history about the mechanism and date of trauma, his hand dominance, whether it's a first-time dislocation or no. And then I'll assess this patient, his neurovascular structure, intact skin. I'll assess his axillary nerve, radial nerve, and ulnar nerve distribution. Following that, I'll give the patient adequate sedation and reduce it using one of the shoulder reduction methods, including inline traction, counter traction method. Following that, I'll get a check X-ray, re-examine his neurovascular status, and document the neurovascular status. I'll put him in a sling, book him a fracture clinic appointment. That's it. That's the most important bits. And then you can, if you have time, you can add some stuff. Those are the common methods of reduction. The most common method you use is the traction counter traction method. There's also the Hippocratic method, the Milch method, Stimson, and the Cochrane's method. But you can only say them if you are asked what are the methods of reduction you have, but usually you use the traction counter traction method. This is a very nice algorithm for post management of first time dislocators by the British Elbow and Shoulder Society. So it basically says that if the patient is less than 25 years, so this is a very high incidence of redislocation. So in 6 weeks, you get an MRI and investigation, you consider repair. 25 to 40 degrees, 25 to 40 years, sorry, you assess them after 6 months and see if they're symptomatic, you can proceed with further imaging. Above 40, very high incidence of rotator cuff injury. So you see them in clinic in 6 months as well, and repair if there's a proven tear, given that the patient is fit enough. Um, the next question is about posterior. So the same question might come, but with this X-ray. Can someone describe the X-ray for me, please?
Yeah, I can go.
Yeah.
So this is an AP radiograph of the left shoulder of a skeletally mature patient. This radiograph is inadequate, and I can see on the left-hand image there is a light bulb sign, which is consistent with a posterior shoulder dislocation. The radiograph on the right-hand side showing congruency between the humeral head and the glenoid cavity, which I suppose would be after reduction of the presumed posterior dislocation. I can't see any other injuries or fractures.
Yeah, that's very good. So it's you manage this similar to the anterior shoulder dislocation, but just I'll give you a tip. Sometimes the scenario might come that the patient is in the medical ward with high sodium. They did an X-ray, and they give you this image. In that case, in a shoulder dislocation of unknown chronicity, you don't reduce it emergently. So you wait till the next day, you get a CT first, wait till the next day till there's a shoulder surgeon with a skill set to open, so that he would try close reduction, and if it failed, he'll try open reduction. So you don't deal with it as a fresh anterior shoulder dislocation if it's unknown chronicity. Right. So our next case, 72 years, Fush, severe shoulder pain, unable to raise the arm. Can someone comment on the X-ray, please?
Yeah, I can go.
Yeah.
So this is an EP radiograph of a 72 years old female. There's an evidence of a proximal right humerus fracture. There is at least a three-part fracture with a fracture line extending to the surgical neck and the greater tuberosity. I would like further orthogonal views to assess the injury. My key concerns here is the high energy injury, and to exclude the neurovascular injury and to exclude fracture dislocation.
All right, that's really good. So yeah, this is an AP radiograph showing it's probably a four-part fracture. So you can say it's in keeping with a near 3 or 4, just gives you an edge. And the joint looks congruent a bit. And yeah, you would like orthogonal views, and you can mention a CT scan as well. How do you classify and decide treatment? So the near classification is a four-part classification depending on how many fragments. So greater tuberosity, lesser tuberosity, articular surface, and humeral shaft. And it's considered separate if the displacement is more than 1 centimeter and the angulation is more than 45 degrees. Let's go back to this. Can someone talk me to the management of this case? How would you manage this case?
Yeah, I can go. So
Guys, if everyone can participate, that would be great. But yeah, you're doing a great job. Thank you. Go.
So yeah, as I said, the main key concern is a high energy injury. So I would like to assess this patient according to ATLS principles and put a trauma call if it's not done. Assemble the team and assign the roles, followed by prime and second survey to exclude any life or limb-threatening injuries, taking an ample history, and in addition to hand dominance, occupation, social history, and smoking status examination, I will assess the neurovascular status of the upper limb, especially the axillary nerve sensation on the regimental bulge area, and exclude open fractures. For the investigation, I would like to have an X-ray or AP shoulder scapular wide view and modified trauma axial view. CT as well. We will consider a CT as well. Management, this patient, I can manage her by colon cuff and add her to the trauma list to be discussed with an upper limb consultant.
That's a very good answer. I would advise, I know that part about the ATLS and getting a trauma call and assigning roles. I thought it was a good answer first, even when I was studying myself, but this is probably a silver trauma. She's an old patient. You don't need to spend that much time in saying about the ATLS. Just try to save your time for something better. So in these cases, just I'll do a primary survey to make sure it's no life or limb threatening injuries, followed by a secondary survey to make sure it's isolated, closed, neurovascular intact, rather than spending like 30 more seconds in saying something that wouldn't add any marks for you. So try to like make much use the best use of your time. You did a good job in taking the history. It's always important here to take the social history and the level of activity as well, because this will dictate how we'll manage her. And then in the management part, try to be a bit more proactive. So yeah, you're add her to the trauma list. You're discussed with an upper limb surgeon, but most probably you can mention the profit trial and say this patient will most probably be managed conservatively. So that's the profit trial, very important trial to know. Just a couple of more information. You wouldn't need them in the exam, but just to be aware, maybe in your portfolio station, it was done on 250 patients on the displaced fractures and more than 16 years old within 3 weeks of injury. They assessed patients according to the Oxford Shoulder Score, and they concluded that surgical intervention doesn't result in better outcome with displaced fracture of the proximal humerus. But there are many, many fallacies about this profit trial, many controversies. So I'll just mention it like roughly. All right, what are the deforming forces in the humeral fractures? So it really depends on where the fracture is. So in proximal humeral fractures, the GT is pulled posterior superiorly by the supraspinatus, and then the lesser tuberosity is medial by the pectoralis pec major. And the shaft is pulled medially by the pec major as well. And then the humeral shaft fractures, it depends exactly where the fracture is. So if the fracture is distal to the deltoid insertion, so the deltoid is gonna abduct the proximal fragment, and the distal fragment will be medialized by the pec major. If it's proximal to the deltoid insertion, so the distal fragment will be pulled by the deltoid instead, and the proximal fragment will be pulled by the pec major medially. Yeah, can anyone talk me through the deltopectoral approach?
Yeah, I can, but I just want to ask a quick question if you don't mind.
Yeah, sure.
Yes, so regarding the proximal humerus fracture, is it worthy to mention the NICE guidelines for the non-complex fracture?
Yeah, you can mention it as a one-line thing. Probably there's no exact management scheme for the proximal humerus fracture. Now they came up with the profit trial. They came up with the NICE guidelines. It depends where you're gonna do it. So if you discuss this case with an upper limb surgeon, he'll have a like in a 76 probably no nothing. It would be a reverse. And yeah, this is something you can mention as well. You can discuss the surgical option, including fixation and arthroplasty. For this patient, probably she'll just need a reverse.
Yeah.
But in a younger patient, 65 years maybe, the management plan will differ according to the functional status of the patient, the level of activity, what does the patient need. So it's not really about a single guideline, but you can mention it as a one-liner, yes.
Because when I was reading through it, it has an indication when to fix the proximal humerus. That's why I was asking.
But that's why I was mentioning they don't really go by it.
Okay.
Have many other factors. So I think the NICE guidelines mentions about like head split, yeah, a comminuted open fracture. Yeah, these are definitely indications for fixation. But this doesn't mean that all the other fractures don't need to be fixed.
Okay. So the deltopectoral approach, in an appropriately marked and consented and Hushik listed patient on timing out, patient will be placed in a beach chair position. And my internervous plane will be between the deltoid supplied by the axillary nerve and the PIC major supplied by the medial and lateral pectoral nerve. My incision would be from the tip of the coracoid to the shoulder or the humerus at the level of the axilla. I will identify afterwards the deltopectoral plan, and then after that retract the cephalic vein as well as the deltoid laterally and the PIC major medially. And then I will split the deltopectoral fascia, and then I will identify the coracoid just to stay lateral to it to protect the neurovascular structures. And this is a light bulb of the shoulder. And then I will split the lateral fascia of the conjoint tendon to identify the subscapularis muscle. Subscapularis will be detached 1 to 2 centimeter proximal to its insertion and reflected, and then we will incise the capsule, closure in layers, and then the dangers here will be the cephalic vein, the musculocutaneous nerve, the axillary nerve, and the circumflex humeral artery.
That's a very good answer. Um, the approach itself was spot on. I don't have any comments. I'll just say one more line about your setup. So yeah, in a properly marked and consented who checklisted patient. So antibiotic and TXA induction position. Sorry, that's wrong. Position is a beach chair position and X-ray from the other side. So give one more line about your setup, but otherwise you did great. Next patient is a 28 years, fell from a bike onto his shoulder, pain and swelling. Anyone, guys? Please, guys, can I have someone new?
If no one wants, I can go for it as well.
Yeah, I can do it if you don't
Okay,
mind.
that's fine. Sorry.
Thank you. Yeah, so it's 28 years old gentleman with high velocity injury. I would like to assess this patient, manage him according
Can
to.
you describe the X-ray first? Yeah.
Oh yeah, so X-ray first. So it's be a view of shoulder with the skeletal mature shoulder with unknown demography, show that disruption of the middle third of the clavicle, which significantly superior displaced. I would like to get extra view, as this is in complete view, as I would like to check the lateral view and the AB of the shoulders themselves. And this is X-ray finding. My main concern is this a high velocity injury. I would like to assess and manage this patient in ATLS. After assuming this is isolated close injury, I would like to check, examine this patient by observations of skin integrity, observation, assessment, and documentation of neurovascular state of the upper limb, sensory and motor, capillary filling, radial pulse. Giving this significant displays, my main concern is the skin integrity, and it might tend to break the skin. Initially, this fracture could be measured conservative by collar and cuff, and after applying of the collar and cuff, I would like to get post collar and cuff X-ray to check how it goes. If any concern about the integrity of the skin, I would like to admit this patient and put him on trauma list for open reduction internal fixation, but most likely this kind of fracture tend to heal with conservative management. Check X-ray in 1 or 2 weeks and take from there.
All right, that's very good. Is skin tenting an absolute indication for fixation of the clavicle?
It's very, very debatable. It's very, very debatable, to be honest. But it's one of the um, indication for open reduction internal fixation is compromising of the skin.
Yeah.
But yeah,
But I wouldn't say that I would need to admit the patient if there's some skin tenting. He can still come to clinic and do it, or like be put in the trauma list and be sent home, right? You don't need really to admit him with skin tenting. That's what I think. Maybe I'm wrong. But yeah, so X-ray, you did a good job. Just need to practice more so he can get all the words out quickly.
yeah,
So this is an AP radiograph of the left clavicle. This is not the shoulder. This is inadequate, showing an oblique fracture of the middle third of the clavicle with superior displacement of the medial fragment. I cannot see any dislocation in the glenohumeral or the AC joint. And I cannot see any obvious rib fractures. Ideally, I would need orthogonal views, get a better view of the chest to rule out pneumo or hemothorax. And then carry on with what you did. You did great. I'll manage this patient as per ATLS protocol. Make sure it's an isolated closed neurovascular intact injury. Then examine this patient clinically by taking an ample history, including the mechanism and date of injury, hand dominance, occupation and level of activity, and smoking index. Then examine the patient, examine the skin integrity for skin tenting, examine the neurovascular structure, particularly the medial, radial, and ulnar nerve. I'll then put the patient in an arm sling and add him to the trauma list. I'll discuss with him our options, operative versus non-operative options, and then we'll go through this now. And one more thing, you said you'll get an X-ray after putting the patient in a sling. I don't think we need to do that. We're not trying to reduce the fracture, right? So no need for an X-ray post-sling. In clinic, yeah, you get definitely an X-ray, but not post-sling. How would you manage? We went through this. So those are I think I put the operative indication somewhere else. Yeah, it's fine. So the indications are open or impending open injury, neurovascular compromise, floating shoulder, significant displacement in selected patients, and the complications are non-union, malunion, and cosmetic deformity. All right, describe the ligamentous anatomy and the deforming forces around the clavicle. So basically, the medial ligaments are the interclavicular ligaments, which are between both clavicles here, and the costoclavicular ligament between the ribs and the clavicle. The lateral ligaments are the CC ligament, coracoclavicular ligament, and the acromioclavicular ligament. Deforming forces, so the medial fragment is pulled superiorly by the sternomastoid, and the lateral fragment is pulled inferiorly by the pec major and the weight of the arm. Those are some papers that could guide your management. So there was the clavicle study. It was done by Royal Free in 2017 on adult patients with displaced midshaft clavicle. They did an open reduction internal fixation. First outcome was the radiological evidence at 3 months and functional outcome using the constant Murray score and the DAS score. There was at 3 months, there was no difference in radiological union. But at 9 months, there were lower proportion of non-union in the operative group, so they were better, and greater patient satisfaction at 6 and 3 months. So basically, they say that in terms of radiology, there's no difference in 3 months, but the functional outcome is different, is better in the operative group. Similar with the Canadian Orthopedic Trauma Society, they reached the same conclusion that improved function scores with the fixation group, but there are risks always with the RF, including need for plate removal, cosmetic deformity, and numbness because of the suprascapular nerve, which is injured during the approach. Those again are the indications for RF. The absolute indications are open, threatened soft tissues, neurovascular injury, floating shoulder. So can someone tell me what's a floating shoulder?
Scapular neck fracture with the clavicle fracture.
symptomatic non-union malunion, and the medial third fractures. Relative indications are significant displacement, neurological deficit, polytrauma, bilateral injuries more than 2 centimeters, and upper limb injuries ipsilateral. Last case, 32 years old, rugby player, immediate pop while wrestling, wrist drop. Yeah, anyone wants to go?
Another go, please.
Yeah.
So what I can see, this is AP and lateral radiograph for the right humerus for skeletal mature patient without patient demograph showing oblique fracture of the mid shaft of the right humerus. I cannot see any other fractures. However, I would request other orthogonal views, including the lateral view of the right humerus, and also I need to get full x-rays for the right elbow to exclude any other injuries there. My main concern for that patient is going to be neurovascular status, especially for the radial nerve, skin in terms of open fracture, and also compartment syndrome.
Yeah. How would you like to manage this patient? Anyone else want to go?
Yeah, I can go.
Yeah.
So in terms of management, I would manage this patient clinically and radiographically. Clinically, I will start by history taking an ample history and a focused history about the mechanism of the injury and how did this happen. Does the patient has any other injuries at all? Then I'll proceed with the clinical examination. I will examine the patient neurologically, especially I'll examine the radial nerve. See if there is any rest or drop and the sensation of the first web space on the dorsal aspect of the hand. And I will assess the vascular status of the patient, specifically by assessing the radial pulse, the ulnar pulse, the capillary fill time, and the temperature. And then I will make sure that this injury is closed and there is no skin tinting or threatening of the soft tissue envelope. And then I will in terms of management, I will need orthogonal views of the humerus and for the elbow joint, above joint, below the elbow and the shoulder. I will make sure that the patient is in a splint in the most position of comfort. I will give him analgesia and I will assess the neurovascular status after application of the splint. I will make sure I document all my findings and all my examinations. And after that, after that, I will if the patient I think is fit and well 32, yeah. So I think he can go home and we will bring him to I will add him to the trauma list. And I will discuss with my senior and will contact him regarding the date and time of the operation. And I will discuss with him all the benefits and the risk and make him aware about the management options for his injury.
All right. That's really good answer. You went through most of the stuff. I would try in when I say the management, first of all, yeah, management will put him in a brace or a splint, yeah, but just mention a brace because it's a common thing to do, and you'll get the check X-ray with the brace because most probably this patient, I don't know, but he might be managed conservatively. The position doesn't look so bad. So you always in humeral shaft fractures get an X-ray in the splint or the brace. And then whenever you're managing a patient, yes, you'll add him to the trauma list, but you're supposed to be the registrar on call. So you have to formulate a plan. So you have to tell them, what do you think your management plan is? Is it operative or non-operative? So you can mention it that this might be a conservative management, and then yeah, you'll add into the trauma list and rediscuss it. But try to give them your view of what do you think, because you need to make a plan. You wouldn't send the patient home and you're on call every day without like a clear plan.
Thank you.
So yeah, I really like that you mentioned exactly how you're gonna assess the radial nerve because it's the most important thing here. So when the nerve is important, yeah, you said about by doing wrist extension and sensation of the dorsal web space. Yeah, you went through everything really well.
Thank you.
So another question, just if the patient had a radial nerve injury before, just he came, you saw him with a radial nerve injury,
Mhm.
what would you do? Would this be for operative or non-operative management?
If the patient is presenting with symptoms of radial nerve injury, so I think this will be for operative management because at that time the nerve need to be explored and fixed or reattached.
Okay, that's fine. All right, so radial nerve symptoms on presentation is not an absolute indication for ORIF. So this is a neuropraxia, most probably, and you can wait and see. You don't have, so if the fracture is not for fixation, it's minimally displaced, but the patient has radial nerve symptoms on admission, you don't need to operate on him. It's fine. You can wait and see. However, if the patient was presented with an intact radial nerve, uh, and then when you put him in a brace or you manipulated or anything, this he developed radial nerve symptoms. So then you have to operate because probably now the nerve is interposed in the fracture. So just
Mm.
wanted to let you guys aware about this because a bit of confusion here.
Oh, so it's the other way around, the other way that I said it. So if the symptoms are pre-brace, this most probably is a neuropraxia and will resolve from its own. But if it's after the brace, so this is the nerve is now entrapped and this need to be explored and yeah, okay, so the other way around.
Uh,
Sorry, I don't be like, I'm not sure if it's difference in practice, but usually if it's just from the brace and it happened, maybe relieving the brace usually resolves it. And I've seen people going home without.
I think yeah, you're correct. You can. I meant that. يعني, you know that the radial nerve is injured now. But for of course, if you took the brace off and the radial nerve symptoms improved, then yeah, you know that the nerve is not interposed, and then you can carry on with your non-op management. But I mean about like if the radial nerves are there's you're sure that there is a radial nerve symptoms following your brace application and they're not resolving. So
Okay.
then you have to explore.
So I have a quick question, if you don't mind, please.
Yeah, sure.
So in terms of this station that you present, we got now, you mentioned in the stem that there is a wrist drop, right?
Yeah.
So would I mention like to put the patient in a extension splint or
Yeah, you can wrist drop splint. You can mention that as well. Yeah.
okay? And when should I say about like for example, this patient now is coming with a wrist drop, so he's having a neuropraxia most commonly. When would you send him for the peripheral nerve injury unit, for example, if this
So
is
usually in real practice, we do it of if there's no resolution of symptoms. So you manage this patient expectantly. For example, you're not operating. If you're gonna operate, so you can inform them. Like so, if you're gonna operate in this patient immediately, you can inform them. But if you're managing this patient expectantly, so you can see him in clinic in 3 to 6 months, and see if the symptoms didn't improve, then you can inform the peripheral nerve injury unit.
so the time frame is 3 to 6 months.
Yeah.
Okay, thank you.
Depends on what you have. So yeah, in that case, yeah, but if you're exploring the patient, you can inform them. And the most important thing is to inform them if, for example, you're operating on a patient and you cut the nerve inside intraop, then you have to inform them immediately as well.
One more note, sorry.
Yeah.
I remember one of my upper limb consultant mentioned the best timing of peripheral nerve study is should be 6 weeks down the line if we tend to go with a conservative management, as it's a good time for recovery. If it doesn't show any sign of progress and healing, I think we can start doing nerve exploration at that time.
Yeah, that's reasonable. I think it differs from one to one. But in my previous trust, I remember a patient we waited like 3 months. So first of all, you do a nerve conduction study. So that was what's happening in real practice. You know what I mean? So you see the patient in 6 weeks, there's no improvement. Then you request a nerve conduction study. Then you see the patient again in a month or so, and then you see what the report is. If the report says there's no improvement at all, we're not expecting any improvement, then you refer. Sometimes they say there is some improvement, so you still wait and see and then refer. It varies a little bit in practice.
Sorry, Ahmed, just again, the question that you mentioned earlier about the closed humeral fracture plus radial nerve policy management,
Yeah.
I didn't get exactly what should I say. Like, how would you like formulate your answer in that question?
So in that case, I'd say so similar to everything. I'll manage this patient to, as per ATLS. I'll document the neurovascular status. I'll put the patient in a brace, followed by a check X-ray. I'll re-examine the neurovascular status of this patient, checking the radial nerve again. If there's no improvement, I'll document that. There is a most probably this is a neuropraxia, so it will be expectant follow-up. That's what I would say.
But yeah, so because you mentioned in your answer down expectant vertex exploration, so I shouldn't mention anything about
No, no,
exploration
no,
in my initial answer.
no. You
Okay,
can mention, but as I've mentioned, you can mention that you'll discuss it, expectant versus exploration, but give them what you think. So what I think is this is a neuropraxia, it will improve.
thank you very much.
Uh,
So Amr, the communist, sorry, Ahmed.
yeah, sure.
So basically, you don't assume that there is an actual injury unless it's lost after the reduction. So any other than this, you expect it's a neuropraxia and will resolve. If it doesn't resolve, then you have to take an action. So no one will touch it before 3 months.
Okay, thank you very much. Thank you.
Uh, Holstein-Lewis fracture. Anyone knows what's that?
So Holstein-Lewis fracture is distal third humeral fracture, and
Yeah,
it's most commonly associated by a radial nerve injury.
sure.
So this fracture, we can't put a humeral splint brace on it, whether we do a above elbow back slab, but it would need surgery if we have symptoms. I think I've heard that they use most commonly a transolecranon approach for it,
No, I
maybe,
don't. No, 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 no,
or
no.
posterior, or maybe posterior approach for the shoulder. Yeah.
Transocular approach, you mostly use it in like condylar comminuted fracture.
Okay.
Supracondylar humerus comminuted. But in the extra-articular, most
Okay.
probably use your normal posterior approach, but it will differ in the implant. So if it's a mid shaft, you put a posterolateral posterior plate, direct posterior, and then if it's a low fracture, you put a double plating, a posterolateral and the medial plate, depending
Okay.
on the configuration you want.
Okay.
Yes, you can mention it's better to put him in a back slab, but just don't make it a part of your answer. So if you see this X-ray, yeah, put it in your management. You put it on a back slab rather than a humeral brace. But if asked about Holstein-Lewis fracture, you don't have to say that this is a contraindication for humeral brace because it might be a little bit high enough that a humeral brace would be all right. So uh, don't say it. Um, Posterior approach. This is my last question. I don't think it came before, but I don't see any
Yeah.
reason.
Yeah. I'm happy to go for it. Yeah.
Go.
Okay. So again, in an appropriately marked and consented and HOSHIC listed patient, and timeout done, given IV antibiotic and tranexamic acid, I'll position my patient in lateral position with the arm over the body. It is a muscle splitting approach for the triceps between the long head and the lateral head, which are supplied by the radial nerve. So my incision would be from the acromion down 8 to 10 according to the site of the fracture, sorry, and that towards the olecranon. I split the skin subcutaneous tissue, identify the interval between the lateral and the long head of the triceps, and I will identify the radial nerve. And then after that, we'll just access the bone, fix the fracture, closure and layers, sorry. And the risks here are the radial nerve.
Yeah, I think that's good. But just try to mention more about the radial nerve, which the thing you're worried about here. So you're gonna split the long and lateral head of tricep, and then you're gonna split the medial head of the triceps. And then you're gonna follow the radial nerve till it pierces the lateral intermuscular septum 7 centimeters above the lateral humeral condyle. And also some people you get X-ray from the other side as well. and some people inject local noradrenaline before incising and give TXA as well. But otherwise, that was good. You can mention like you can do a triceps sparing approach as well if the fracture. So in a Lewis fracture, you can do a triceps triceps sparing approach as well, rather than triceps splitting. But this is the one most usually done here. Thank you all. Any questions? I hope this was a bit useful.
That's perfect, Ahmed. Thank you so much for that. That's a really good good way, I think. So, like putting a case, getting answers, and then give the model answer. I think that's one of the best ways to make it both interactive and informative. Good. Guys, do you have any questions for Ahmed? I think he did a great job, and I think all the questions came through the talk.
Thank you very much.
No worries. So, very good. We are ahead of time, so we have like 18 minutes. Ahmed, do you mind to share the slides with them?
Yeah, sure.
So just send it to me, so I put it in the group. Don't put it in the chat because the chat will disappear with the end of the session. So just send it to me and I will put it in the group.
Yeah.
Good, guys. So shall we have a break before we go for they were moving now more distal, so going to wrist and hand. So I think we'll stop for a break for 15 minutes. We'll be a bit more break, so we can restart at 10:40. So something like 17 minutes from now. So 10:40 we'll be back. We'll start with speaking about wrist and hand, then we'll go to the beads. So please be on time. No, we have an elbow session first. Oh, sorry for that. I missed that. So yeah, so 10:40 we'll have the elbow session, then we'll go for wrist and hand, then after that the beads, then we'll go for the mock. So please keep on the call, just put your cameras off and microphones off, and I will see you again at 10:40. So welcome back, guys. Just a quick one before we go ahead, clarification regarding the radial nerve. So if you have a fractured humerus and it has a nerve symptoms, so you assuming this nerve is a neuropraxia until you're sure it is injured. And the only way you get sure it's injured, either you open it when you do an operative treatment, or if it's iatrogenically injured when it becomes they become nerve symptoms after the reduction. So if you do a reduction and the nerve symptoms were in there and now they have nerve symptoms, you sure you have iatrogenically injured it, and that's the time this nerve needs to be referred to the peripheral nerve unit. Even in the new practice, we even wait on it, so we don't send it to the peripheral nerve unit straight away. But if not, so all the nerve injuries associated with humeral fracture is neuropraxia until proven otherwise. And this patient, you keep an watchful eye on them for 3 months before you refer to him to anyone. Yes, you bought a cock-up splint, refer to physiotherapy, ensure they do the exercises. And so basically, if you get this question in the exam, so if I will treat operatively, so definitely I will open and I will explore the nerve. That's part of the approach of the posterior approach if I do a posterior approach. If I will not treat it operatively, so I will keep an eye on it unless it happens after my reduction. I'll keep an eye on it for 3 months, cock-up splint, physiotherapy, and at 3 months point, if it's not coming back, I will do a nerve conduction and refer to the peripheral nerve unit. So what we will do if you encountered into the approach, so if there is a nerve injury and you're treating this fracture operatively, and you open your approach and the nerve is injured. If the nerve is just contused and still in continuity, you don't do anything. If the nerve is injured, so even the peripheral nerve unit, they don't repair acutely except a clean cut. So if it's because that's a contused injury, it's not a clean cut. So what you will do, you just mark the ends and then close, continue your fixation and close, and the peripheral nerve unit surgeon will interfere at 3 months point. Peripheral nerve unit, the nerves in general, the peripheral nerve surgeon or the plastic surgeon, whoever is doing the peripheral repair nerve repair in your unit, they always only repair the clean cut. So the cut you do iatrogenically by your knife. That's the cut which can be repaired acutely. Most of the other injuries to the nerve is repaired after 3 months. You just mark the ends. So you just take you put a tag here on the both ends, keep them attached to the muscle, and then refer it to the peripheral nerve unit, which they plan a surgery within 3 months. So that's quickly the whole answer. So on the new guidelines, on the new practice, I'm not aware of the guidelines, but even in the new guidelines, so even if it comes iatrogenically after reduction, a lot of surgeons wait on it. So don't refer him directly to the peripheral nerve unit. But it is medical legal, you have to refer to the peripheral nerve unit if it comes iatrogenically after your reduction. I hope that's clear to all of you.
Thank you, Mr. Hashim. Just a quick question, if time allows.
Sure.
Is there a reason why we not fix or be attached the nerve if it's confused or not a clean cut, like
Yeah,
specific
so
reason?
basically, yeah, because the degeneration process starts straight away. So the ends you see in front of you is actually just empty socket. So the risk for it to make a neuroma is much more than to have a proper repair. That's why you give it the time for the valinia degeneration to happen. Then at up to 3 months, so depends on the protocol. Some come at 6 weeks, come at 3 months. They go in, they refresh the ends, and they do either a primary repair or a graft or whatever they do. Unless you did a clean cut, there is no one who will repair it straight away. Clean cut means you cut it with your knife. So if you cut it with your knife while you're doing the approach, you can call the plastics or the peripheral nerve and they will come and repair it on spot. Other than this, any contused injury, they refer it for at least 6 to 12 weeks.
Thank you.
The nerve ends is not like any other tissues. Sometimes they are not healthy. So they don't risk the repair on an unhealthy ends. That's why they wait for the valinia degeneration to happen. The cuts clean itself and get all the dead tissue out. And now they are clean cuts, and then they decide, oh, this can be primarily repaired with some release or not. It needs a graft or cable, whatever they do. So that's why unless you cleanly cut it with a knife, they don't repair it on the spot. Faris, you ready? So Faris will take us through, Faris and Ahmed Ghazal will take us through elbow. So yeah, quite a nice and quick job. So hopefully we'll be okay. Faris?
Yeah, I'm here.
Perfect. We share your screen, please.
No problem.
That's great. Okay, go ahead.
So, hello everyone. I'm Faris. So today we are this session is going to be about elbow and the main clinical scenarios that comes in the elbow and how to kind of structure your answer and what to focus on and what kind of maybe some papers that might come up in this in elbow scenarios. So learning outcomes would be to basically have a confidence of approaching any sort of elbow trauma scenario and having a structured framework or a spiel when answering your questions and how to kind of interpret the common images and how to do a good management plan. And just recall a bit of elbow anatomy and biomechanics, which you might have covered already in the earlier sessions. And no different types of classifications. And also to be able to apply evidence-based orthopedic principles. So, for example, for this slide, elbow anatomy is very common. So basically just to know your main anatomy, for example, your articulation surfaces that you might have had it done during your MRCS exams, know your just basic skeletal anatomy, and here, for example, you need to focus on your elbow stabilizers, your static and dynamic stabilizers, which I'll talk about later on in the next slides. And then you also have like the compartments, which We're going to cover in the wrist, and I think my colleagues earlier might have covered as well. So know your muscles for our forearm anatomy, so they can give you a cross section from anywhere from the shoulder all the way to the wrist or even hands. So try to look at as many cross-sectional anatomy. They can also give you just a coronal kind of image, and they'll be like, label these diagrams and what nerves are supplied by them. So try to look at many cross-section, and that's what I did last year, which is the hardest bit. But in the end, when you get an image, it'll make your life so much easier. For example, in the extensor compartment here, brachioradialis, where does it originate from? The lateral supracondylar ridge, inserts in the styloid process of the radius. And what's its action? Basically elbow flexion and supplied by the radial nerve. And then in the forearm flexors, you have the FCR, pronator teres, palmaris longus, which are all supplied by the median nerve. And then you have the FCR and palmaris longus, they are all originate from the common flexor origin. And then, for example, the FCR will insert at the base of the second and third metacarpals. So here's kind of like a summary, which I kind of have to try to memorize. You have your superficial and your deep compartments of your flexor forearms. So have an idea what's their actions, where do they originate and insert from, and the main nerves. And then this is what you have for your extensor compartment, your superficial and your deep compartments. And always just have an idea, deep majority of them is supplied by the PIN. So here, other question that I can ask you is, what are the borders of the antecubital fossa? So you have your medial border supplied from the pronator teres, superior border. You have the transverse line between the medial and lateral line of the epicondyle of the humerus, and then your lateral borders, which are the brachioradialis. They can then also ask you, okay, so what are the contents? So a nice way I always remembered it from lateral to medial, tan. Tan is the tendon, which is the tendon of biceps. A is the artery, so it's the brachial artery, and N is the median nerve. And then these are what I was mentioning earlier about the elbow stabilizers. So this is important because sometimes they can ask you in this location, what are the stabilizers in the joint? So you can easily divide them into, you can say that during dislocations, if the elbow ligamentous damage always occurs. So it's usually from lateral to medial, and you have primary and static. So your static stabilizers, the primary is the ulnohumeral joint, the anterior MCL bundle, and you have the LCL complex. And then you have your secondary static stabilizers, which is your radiocapitellar joints, joint capsule, and your flexor extensor origin. Then after that, we can move on to dynamic stabilizers, which are easier to memorize, which is the onconius, brachialis, and the triceps, which are the main muscles. So the course of the peripheral nerve, you probably have had this already gone through, but it's very, very important to try and summarize it in a very easy way to help yourself, because that was the hardest bit of studying all the courses of peripheral nerve. So try to have kind of a small bullet points, and like the way I've learned it, that's how I kind of usually used to do it. It's like the radial nerve is a branch of the posterior cord, arises from C5 to T1. It leaves the axilla through the triangle interval with the profunda brachii artery, and then in the spiral groove of the humerus, lying in the posterior compartment of the arm. So then it pierces the lateral intramuscular septum to leave the posterior compartment and enter the cubital fossa at the lateral epicondyle. And then here it divides into superficial radial nerve, which is the sensory, and the posterior interosseous nerve. So sometimes they can just say, describe the pathway of the radial nerve from the brachial plexus only to the elbow. So that then you can just say that. However, they might say then describe the pathway of the radial nerve from the elbow to the hand. So from there, you can say that it has two branches. You have your superficial radial nerve and the PIN. And the superficial radial nerve, you can say that it lies on the lateral side of the radial artery beneath the brachioradialis in the forearm. And its terminal branches then pass superficial to the tendons of the anatomical snuff box to supply the dorsum of the hand. And then the PIN, as its origin is in the cubital fossa, the PIN pierces the supinators about 3 centimeters distal to the head of the radius and runs in the extensor compartment of the forearm beneath the interosseous membrane of the wrist. And then it supplies all the supinators and all forearm extensors. And then sometimes they might say, okay, so how would you test the branches of the radial nerve? So you can say that sensory is the skin over the anatomical snuff box. So if you feel the sensation there, then you know your sensory is intact. And motor function of the radial nerve will be extension of the wrist, and that's mainly the PIN nerve. And then sometimes they might go and say, oh, what muscles does it supply? So then you could say that motor supplies the triceps, anconeus, brachioradialis, and extensor capiloradialis. And the sensory supply would be the posterior cutaneous nerve of the arm and forearm, and you also have the lateral cutaneous nerve of the arm. So try how to kind of summarize how you kind of have a small kind of bullet points, because at the end of the day, you want to be able to just say where it originates, where it goes through, where does it loop around, and where does it go, which muscles, and it's the same with the ulnar nerve. So you can say that the ulnar nerve originates from the medial cord, from C8 to T1, travel between the axillary artery and vein, goes into the medial intermuscular septum, and then the posterior medial aspect of the medial epicondyle through the cubital tunnel. Then it goes through the 2 heads of the FCU, and then the distal form runs with the ulnar artery, and then the FC, and then it goes and enters the hand with the ulnar artery via the Guyon's canal. So you can just summarize it very small. As long as you mention these main buzzwords on where it's located, then you'll be fine. And then these are examples of the cross-sectional that they can ask you around the elbow region, which once you kind of get the hang of it and practice, and I think there's a lot of, on Google, you can just search quiz cross-sectional anatomy. You can try find so many of them. I try to just answer as many because they can give you different variation, different views, different angles, and it's a lot of muscles to know. So, but I think once you kind of know one cross section, it's always the same muscles that repeat. So, like for example, you can see FCU here on this section. It looks a bit different. The FCU is still here, so FCU is still here. So you can see where FDS, FDP, FCU, and you have your median nerves. So and then you have the median nerve here. So usually there is a lot of repetition. Median nerve is here, but the format changes. So always try to make it easier. The way I've learned is always, oh, which one is the radius, which is the ulna. If the ulna is there, it's going to be the FCU here, and then kind of have a systematic approach on how to know the muscles around it. So try to find I usually start with the bones, know where the radius, where's the ulna, and then work my way around it. And then usually once you have a systematic approach on how to memorize the muscles, it makes it much, much easier. So that was just a kind of a bit of a brief view on the anatomy that you need to know around the elbow region. Going to the clinical scenarios, so there's not really many clinical scenarios from the elbow point of view, apart from the main ones, which will be this one, for example. They can just ask a 55-year-old gentleman has fallen on his left elbow, and you're asked to see this gentleman, and they will maybe just ask, how are you going to interpret this radiograph? So basically, the main thing to always interpreting radiographs, you had a session about it earlier, is basically you need to kind of interpret it by having the view and what view is it. You have the patient factor, whether is there any details, the date in which it's been taken, the bone joint assessment, and then if there's any classification that you are aware of, it'll be nice to mention it during when you're interpreting your radiograph. So for example, if I've seen this during the interview, I would say that this is a lateral radiograph of a skeletally mature patient taken at unknown time of an unknown patient. And the most obvious finding here I can see is a displaced transverse olecranon fracture with minimal comminution. So according to the Mayo classification, this is a type 2A. So it's displaced but stable, and it's not comminuted. And then if they ask, how would you manage this patient? So usually it's always how it goes. So for anyone, you need to kind of, before you enter the interview, have a very good spiel on what you're gonna say, because this is always gonna come. So how would you manage this patient? Have a spiel for if it's a trauma scenario, have a spiel for that. If it's a general isolated close injury, have a spiel for that. So always have a structure. What's your initial assessment? Use ATLS approach, primary, secondary survey, exclude limb or life-threatening, have a history, ample hand dominance, occupation, medical, social history. For this patient, it'll be important to know about, is he smoking? What is his daily activity of living and his functional status? Or if there's any other previous elbow issues or dislocations. And it's always important to know when the last time the patient had something to eat or drink. And you'd want to also examine the injured limb. So if it's an isolated injury, you want to check examination, skin integrity. If it's an elbow fracture, always extensor mechanism you'd want to assess, because this will help you guide you with your management plan. And then on palpation, you want to palpate any bony gaps. And following that, you want to assess neurovascular status, which you want to assess the motor and sensory function of the radial, medial, and ulnar nerve, and as well as capillary fill time. And then you move on to treatment plan, which what do you want to do? You want to initially do stabilization. So what are you going to do in A&E? Make sure you give analgesia, apply an above elbow backslap, polysling, and check x-rays. And then preoperative preparation would include always keep the patient nil by mouth, add to trauma list, consent and mark the patient, and discuss him in the morning trauma meeting. And then if it was comminuted, so in the always I want to get an AP and lateral views of the elbow, and you can consider a CT scan if it's comminuted, to help with your guidance. Sometimes I might say, oh, is there any other additional radiograph that you'd want? You can say you'd want radiocapitellar views. And the reason why we do radiocapitellar views is to assess associated radial head fractures. So in this kind of scenario, how I would approach it would be like, okay, so this is a patient that has likely sustained a high energy mechanism. I would therefore ensure that patient has been managed according to the ATLS principles using an ATE approach, doing a primary and secondary survey to rule out any limb or life-threatening conditions. And once I'm happy this is it's an isolated closed injury, I'll take a focused ample history, including hand dominance, occupation, social history, smoking status, previous dislocations, and last time he had something to eat and drink. And then I would examine the affected limb by assessing the skin integrity, checking whether it's a closed or open injury, check for any swelling or bruising, and check if the extensor mechanism is intact at any palpable, by checking if there's any palpable gaps. And then I'll assess the neurovascular structure distally, checking the motor and sensory function of the radial, medial, and ulnar nerve, and then I'll assess the capillary fill time. Following that, I'll make sure the patient is given advocate analgesia, and I'll place him in above elbow backslap, polysling. And then I would consent to mark the patient, keep him nil by mouth, out to the trauma list, and give him advocate analgesia and get check x-rays. So that's what I would literally say, and it should take you no more than about 15 seconds to say. So just always have a systematic approach on how you're going to do it, and make sure you just say the buzzwords, and just always have a systematic approach. Assess history, examine, evaluate the neurovascular status, and then your treatment plan. What are you going to do in A&E? What check x-rays you want to do, and make sure you always mark and consent the patient as if what you're going to be doing as an SHO or a reg when you're on call and seeing this patient for the first time in A&E. And then after that, you're going to get an elbow. They're going to be like, okay, you mentioned about Mayo classification. So can you tell me, what do you know about Mayo classification? Can you elaborate more? You can say Mayo classification is one of the easiest ones to actually learn. There's only 3 types. So there's the modified Mayo classification, which is type 1 basically is undisplaced. Type 2 is displaced but stable, and type 3 is displaced but unstable. And then these ones can further, so you can find different classifications, which even these type 1 to type 3, there's even subdivisions. There's type 1 A and B. B is just always comminuted, okay? And then I think there's also an old Mayo classification, which you can also learn. So depending whatever one is easier, but I've learned this one, which is makes it easier for me to learn. And then surgical management options, which I also noticed yesterday during the mocks. It's very, very important to kind of divide them into non-operative and operative. And it's always, even though if you know your case is going to need definitely operative fixation, always just mention non-operative fixation, that there is non-operative. But however, in this scenario, patient is, for example, was an impacting neck of femur, it was a young patient, to say, however, there's operative management. Because especially with these elbow olecranon fractures, there's always a chance that you can treat them non-operatively in the elderly population, depending on if it's a high demanding patient or a low demanding patient. So always remember to mention non-operative management. So non-operative management basically is for undisplaced fractures, displaced fractures in low demanding elderly population. For example, above the age of 75, give them an above elbow back slab for about 1 week, see him in clinic, take him off the cast, and begin early range of motion to prevent elbow stiffness. And then the operative management would be tension band wiring. It could be ORIF if it's a comminuted fracture or a Montega, or there's fracture dislocation or any fracture associated with the coronoid. So here they can also ask about tension band wiring. Operative, I haven't really gone too much, but if you go through your AO website, talk about tension band wiring, what kind of K wires, what's the approach, and what's the configuration with the how we're going to do the tension band wiring. They might ask you that. So sometimes they can also ask what types of fractures can undergo tension band wiring and how does tension band wiring work. So you can say, for example, olecranon fractures, they are transverse in nature with no comminution, and are amenable to tension band wiring. And why is that? Is because you need to know that how does the tension band wiring work. So they usually convert tensile forces from the pull of the extensor mechanism to a compressive force at the joint. And that's all you need to say on how does basically tension band wiring work. So it's converting tensile forces from the pull of the extensor mechanism to a compressive force at the joint surface. And then here you can see some tension band wiring for olecranon fixation. And then these are being back slab for elderly population or undisplaced olecranon fractures. And it is also very important to know if the extensor mechanism is intact. The only paper that I've actually learned for this olecranon fracture, which would be good for you guys, is to learn the Duckworth et al. Study. So this was a prospective randomized trial was done for non-operative versus operative management of olecranon fractures in the elderly, and it was done in the UK. It was a very kind of good paper to kind of quote, and it's very simple because, to be honest, this study was stopped very prematurely because of the high rate of complications in the operative group. I think the investigators found it like unacceptable and unethical, and they found a high rate of risks in the operative group in the elderly population. I believe they were looking at patients mainly kind of displaced type 2 Mayo fractures in the greater than 75 years of age. And they were just looking at operative versus non-operative. And then the decision and I think they just found that the decision between what they concluded from the paper, because I think they only had 17 patients in their trial, and then that was stopped. And the only thing they basically found that the decision to make an operative or non-operative decision should be individualized, considering the patient's age, comorbidities, functional demand, the fracture characteristics, and from that perspective. So it's a very kind of nice journal trial to kind of mention. Another elbow scenario that can come would be if a patient they might just ask you, a young person has fallen off a horse, landing heavily on the extended elbow, and you've been asked to see her in ED. So this will be the same. So always have, what view do we have? It's AP and lateral view. Which side? Some people a lot of times like, oh, this might be the right elbow. If it's not, some majority of the time it'll be written if it's right or left. If it's not, then you can just say it's elbow. Don't waste too much time. Be like left, right. Like it's hard. I mean, you can just say this. it's not mentioned. However, if it's obviously known that you can see that it's a right elbow, then say it's a right elbow. And always say, what's the patient's 37, skeletally mature patient, and the time and identity. So just unknown time, taken unknown period of unknown patient. And then always just first thing you need to mention is always what can you see? So basically this is a posterior lateral elbow dislocation, and you can say there's no obvious associated fractures, and then just move on. And then how do you manage this patient? It's always similar. Always have a structural approach. So ATLS, so this is a high energy trauma. ATLS, use an ATE assessment, rule out any limb or life-threatening conditions. If there's no other, and the patient's hemodynamically stable, and knowing that it's an isolated closed injury, I'll do a focused ample history. As I say, know about allergies, hand dominance, social status, last time the patient had something to eat and drink. After that, I'd want to examine it, the skin, soft tissue, whether it's an open closed injury, and check for any bruising, swelling. And then we want to assess the neurovascular status, which will be again radial, medial, ulnar nerve, and talk about sensory motor. And then after that, you want to make sure patient is given adequate sedation. And then I'd want to try immediately reduce this in A&E. And then after that, you'd want to assess stability. So you want to assess it at 90 degrees, 60 degrees, 30, 0, and apply a back slab at 90-degree flexion. And then get post-reduction imaging and reassess the neurovascular status, and say that I'll document this very clearly. Sometimes they'll say, how would you perform the reduction? So always say, but if they don't ask you, so always have a spiel on, okay, I'm just going to reduce it. Is that because maybe in their marking scheme, they might not want to know about how you're going to reduce it. So try to be like, okay, I'm going to reduce it. But if they feel that, okay, you left that out, they will say, as long as you cover everything, you've ticked the box, they might come back to you and be like, okay, so how are you going to perform this reduction technique? So I was saying, I would adequately sedate this patient. I'll speak to my A&E colleagues, get them to a monitoring bay and resus. And then I would provide, then I would try to reduce this with an assistant. So I would provide inline traction and counter traction. And I'll correct the medial and lateral translation, and I will probably flex the elbow with pressure over the olecranon using my thumb. Once it's reduced, then I'd want to assess the stability at different degrees at 90, 60, 30, 0, because that's very important in helping whether if it's very unstable or not, because maybe at 90 degrees it will just dislocate. And then I would say after that, and after checking the stability, I would put it in above elbow back slab at 90 degrees, because 90 degrees is the most stable position for the elbow to stay in place. And then I'll assess neurovascular and get check x-ray. But then sometimes they might say, okay, if the patient is stable, it's not dislocating, what you're going to do, if it's neurovascular intact, you can send home. However, if you're not confident, you can just admit overnight and then let the consultant see in the morning and discharge. But usually if it's a stable elbow, you can discharge him and see him in clinic the following week. And then that's the follow-up for stable, unstable. So as I mentioned already, stable, back slab at 90 degrees, discharge, review in 1 week, repeat x-rays, and then if congruent, start early range of motion. And then this patient will be for non-operative treatment. However, if it's unstable elbow means if it dislocates very easily at about like 90 degrees and it just pops out, then you'll need to put them in a back slab for 7 to 10 days, early clinic follow-up. And then if unstable, you need to refer to an upper limb surgeon, get MRI, and plus minus for ligament injury, to assess for ligament injury, and consider surgical repair. And then the possible follow-up questions with elbow dislocation will be, for example, terrible triad. So you need to know what's a terrible triad. So they can ask you, okay, what's terrible triad? You can say it's involvement of it's 3 factors. It's elbow dislocation, coronoid fracture, and radial head fracture, and plus LCL injury pattern. Other things they can ask about operative indication. So when do we operate these? If it's a complex dislocation, persistent instability, cannot reduce closed, and the fixation order. They love to ask this question about what's your order of fixation. So it's always radial head, coronoid, and the lateral collateral ligament. And then the ligament injury patterns will be a clockwise progression, posterior lateral dislocation, and LCL injury. So the LCL always gets injured first. So the take-home message in this will be develop a clear, consistent, systematic kind of approach on how to interpret radiographs. So for any radiograph you get on the interview, always try to answer it concise, because at the end of the day, you have limited points to get on the X-ray. So don't try to overdo yourself and waste so much time and your time. So just say what it is, the identity of the patient. Is there any kind of interpretation? And if there's a classification that you know that's going to come in your head directly, just mention it. And that's it. And the fracture configuration. But don't go ahead, oh, I cannot see anything on the radius. I cannot see anything on the coronoid. I don't think there is any terrible triad. So if you say all this, you're just wasting so much time and you're not going to get to the end of the station, because the key thing is time is very limited in these clinical scenarios. You have limited time, so you need to be as quick as possible and concise. And every trauma scenario have an always structured assessment framework. So the assessment framework is always the same for any scenario. So just have that prepared. Even now, there's still 4 months down the line for the interview. So always try to refine it, make it better, shorter, and sound slicker. And then always refer to evidence-based guidelines. So for example, the olecranon fractures, this Duckworth paper takes literally about 5 minutes to read. It's a Duckworth trial. It looked at 17 patients. It's checking for operative versus non-operative in elderly population. It was stopped prematurely, and the take home from that is basically operative fixation depends on the patient factor, age, dominance, and that's how they kind of went. And that's it. I already know this paper, very easy one to learn off, and you can mention it, and that's to get extra points. And know your anatomy. So the way I've studied was always learn all the clinical scenarios inside out, have my spills ready, everything sorted out, and then I focus on anatomy heavily, because anatomy will be the extra points for one of the stations. So you usually get a trauma scenario, then you'd get like either a spine or whatever, which will be kind of like an isolated injury. So the trauma always kind of comes, and anatomy will come in either one of the clinical scenarios. So know your anatomy, but it's not the end of the world, because anatomy is really huge. So you need to know the anatomy from the neck all the way down to the foot. So it's a lot to know, but try have a systematic approach and try to make sure that you master all the scenarios and then focus on anatomy for each topic, and practice early. So what I've done, I've always practiced. Well, I had 1-2 colleagues practice from very, very, very early, and it's just every day, at least an hour after work, just go through scenarios and be crucial. Don't say, yeah, you did well. Try to give them the negative feedback, because good feedback is, okay, yeah, you're good, but always try to make every day, try to get better from practicing with your friends. And yeah, good luck and all the best in your interviews.
I just have a quick question. Thank you for your presentation.
Yeah.
Regarding citing the papers, actually, I've been advised by many of the senior trainees that avoid that, because you might dig your own grave. The problem is, if you get a malignant consultant, for example, they can just okay, what is the, you know what I mean? What is the big
Yeah.
this paper?
So citing the papers would be, it's not, I won't cite it directly when they give you an X-ray of the olecranon and be like, okay, cite the paper. But then sometimes they would say, oh, what are factors? So sometimes they might bring a question that would be related to a paper. So they might say, oh, so what are the factors that makes you operate or non-operate? So then if they ask you that question, they were like, okay, so the Duckworth paper was about checking operative fixation elder. So you say, yeah, I read a paper about Duckworth. So it depends on the question they ask you. So yeah, so citing paper is, some people, you can leave citing paper because it's a lot of papers, but you need to know your post guidelines. You need to know all the BOS guidelines. So you have to download all the BOS guidelines. That's the main ones you need to do for trauma, peripheral nerve. So as Mr. Hashim was speaking about peripheral nerve injury, so know your BOS guidelines for that. If you get a tumor or infection, know the BOS guidelines for that, or metalwork infection, There's Bose guidelines for everything. So the main thing is to learn all your Bose guidelines. Papers are kind of extra because, as you said, it might not come and you might not actually need it. But I mean, for my personal experience, I kind of studied the main papers that come like for our trials, like the draft trial, the craft trial. These ones are kind of stuff you need to learn, but it doesn't mean you're going to come. So for me, I didn't quote any papers, to be honest. So it's not something that would come. Because sometimes even prioritization, if they might get you an olecranon fracture to say, oh, current thingy, this is that if extensor mechanism is intact, blah, 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 I would treat conservatively. But as you said, yeah, it's not, yeah, you don't want to dig yourself in a grave. If you don't know the paper, I wouldn't mention it. And if the question is not related to a paper, even if you know the paper, don't try to squeeze it and put it in. So it's a fine balance. Does that make sense, Amr?
Yeah, thank you very much.
Yeah, so
Okay.
Amr, there is signposting papers, so you cannot miss it, and it's no problem to cite it, and even if he asks you about, so don't quote every paper unless you are sure of the content. But there
Yeah.
is signposting papers which needs to be there. So yeah, so Proffer, Heel Trial, Topcat, these not papers. This actually
There's trials.
signposting there. You have to have it. So that's equal to a guideline, nice guidelines or a post guidelines or whatever. So I mean, there is because they are the main evidence we practicing based on. So whatever trial you are using, so you code it in your daily practice. So if I speak to a calcaneal fracture patient, I will code the Hill trial in my discussion with him. So it's not evidence, just like any paper or evidence. It's more of a signposting. So this will guide the way. So I will not operate on you based on the Heal trial, which has that, and this is the fallacies of the paper or the trial. So I think there is well-standing papers which needs to be known in every topic, and you have to mention it. And I don't think he will be bothered a lot if you don't have all the details of the paper. But at least you know the conclusion, you know the strengths and weaknesses of the paper, so you know when to quote it and when not to do. But I don't think he will be bothered a lot by a lot of details if you don't have all the details of the paper.
Yeah,
But I
Yeah, just
cannot in a proximal humor fracture without proper trial. You're missing something. It's not an evidence. It's part of the discussion.
okay.
Get
Thank
my
you.
point?
exactly.
Yeah.
It's part of your management plan, basically. So it's part of
Exactly.
your
Not every paper and not like something which is no one knows about. Will he will start asking you what this paper and what's why you quote here, what's positive, what's negative. No, but I mean the main trials, the main papers, which is directing the management, needs to be quoted in this in your answer. Good. Thank you so Faris, thank you so much. Do you mind sharing the slides if you there is no pressure if you don't want. It's up
Yeah,
to
no,
you.
that's fine. That's completely fine. Yeah.
Yeah, just send it to me on WhatsApp and I will put it in the group just to stay there.
Yes, that's
Perfect. Good. Thank you so much for your time, Faris. Appreciate that. Mamdouh, are you ready to share your screen for the wrist and hand? Please.
Good morning, everyone.
Morning.
Do you see my presentation?
Yeah, perfect. Yeah, if you make a slideshow, it'll be great. Perfect. That's perfect. Good.
Oh, it stopped. What's going on? Something happened. Do you see my screen?
No, yeah, we do see the whole screen. I mean, if you go to share again and
Yeah.
choose, yeah,
Do you see it now? Okay.
Yeah, we do, yeah.
Good morning, everyone. I'm Mamdouh Bannan, ST5 in Wales. I will not compete with these lovely presentations from yesterday and today. They did a great effort, and thanks for Dr. Hashim for organizing this course. I will speak with you guys today about the hand and wrist, but I will not follow the anatomy, then end up after the anatomy to give you cases. I will do it like an integrated anatomy with the approach, with the clinical cases together. What you need to get out from today is anatomy. You need to know about the forearm. You need to know about the wrist anatomy. And when we speak about the wrist anatomy, there are certain points. What are the structures passing below the transverse carpal tunnel and extensor wrist. And hand anatomy, it's a huge topic. I will not take it all, but I will pick up the relative to us. From the clinical point, we will discuss about the distal radius, perilunate dislocations, and scaphoid fractures, flexor tendon sheath, and approaches. We will speak about the common approaches for the forearm mainly, and operations about certain operations, carpal tunnel and flexor sheaths. If we go for the anatomy, we'll take first the forearm. What you need to know about the forearm. All of us are aware that the forearm is radius and ulnar, but you need to know how they articulate together. So you need to know about the anatomy of the proximal radioulnar joint and the distal radioulnar joint and how it works in terms of supination, pronation. Because this is the point. You'll be aware why the ulnar is straight and the radius is curved. You don't need to know where exactly the muscles are attached except for the parts for the approach. You can revise it, you can get it all, and you get the muscle anatomy and nerve supply. You have to be aware of the nerve supply. But if we talk about the forearm, so we have two compartments mainly in the forearm. The flexor, which is the anterior compartment, and the posterior, which is the extensor compartment. If we split the flexor compartment, so you can split it into 3 layers: superficial layer, intermediate layer, and deep layer. So what's the significance for that? Significance, you can easily understand the nerve supply. So if we talk about the superficial layer, you have the pronator teres, flexor carpi radialis, flexor carpi ulnaris, and nes longus. If you're talking about the intermediates, you have palmaris longus. You have the intermediate FDS, and you have the deep layer is the FDP, and FPL and PD. Pronator quadratus, sorry, this is wrong. The deep layer is supplied by the anterior interosseous nerve. So in your mind, when I ask you in the exam or any question, oh, what's the anterior interosseous nerve muscle supply? You can easily, in your mind, you're talking about the deep layer. So the intermediate, the FDS, then, oh, this is a median nerve. Then if you go superficial, oh, this is median and ulnar nerve. What else is important when you understand the compartment of the hands or the forearm, sorry? It's mainly if you have a compartment syndrome. So if anyone asks you about a compartment syndrome question, I need to do a release of the flexor compartment. These layers are splitted by fascia. Normally they can easily be torn with any injury, but sometimes you have to be aware that you need to release all the compartments down to the bone. So if anyone asks you, you need to split them in a way, or you have to make sure that I release all compartments to the bone. In the posterior compartment, it's all supplied mainly by the radial nerve and the posterior interosseous. So you have to split it into superficial and deep layer. You need to revise to know the anatomy in terms of origin and insertion, in addition to a function. So if I ask you, if you will be asked in a question like a distal radius, patient had a distal radius fracture and be managed in a plaster. Later on, he came to your clinic with unable to move the thumb. So why? So what actually do the extension and abduction to the thumb? You have to memorize all this one. It's very hard to give it to you in 20, 30 minutes. Now, this is how you can memorize. I am bad in memorizing written words, but I like to draw the pictures and memorize the diagram. So if you have here the split of a muscles, forearm, an anterior, middle, a superficial, middle, and deep layers. If you go to the anterior compartment, then, as we said, it's supplied by the median nerve and supplied by the ulnar nerve. You have to know exactly what is the anatomy for the median nerve and the ulnar nerve. So if we talk about the median nerve supply comes from which roots? From C5 to T1. And keep it in mind, from median nerve and radial nerve, it's C5 to T1. Then What are the main supplies for the median nerve in the hand? If I ask you today, you can summarize 1, 2, 3, 4, 5, 6. I don't need this. I need you to know what's the clinical importance. So if we talk about the anterior interosseous and we spoke about the median nerve, why it's important. This differentiates the level of the injury of the median nerve. Higher median nerve and the patient lose the function of the anterior interosseous, then you lose the muscles from the anterior interosseous. If lower than the anterior and the split and gives you the anterior interosseous, then these muscles will be spared. So you correlate it to your anatomy. If you go more distally, the clinical significance of the median nerve, it's mainly around the carpal tunnel. So in the carpal tunnel, you need to be aware about the palmocutaneous branch of the median nerve, which is actually released 5 centimeters below the transverse crease of the wrist. Why it's important? It has two importance. One of them is if you have an injury of the median nerve higher than this level, it will be affected. If you have an injury to the median nerve below it, then it will be spared. And this is very common question. They can easily trick you for this one. What else they will ask you for? You have recurrent motor branch of the median nerve. The recurrent motor branch, the significance of this question is mainly when they ask you about the carpal tunnel release. If they ask you what you will look for when you do the carpal tunnel release, then you have to say, I will look for the recurrent, make sure I protect the recurrent motor nerve of the median nerve because it supplies the thinner eminence muscles. That's why my approach will be more ulnar. You can easily injure it. So one of the examiners will ask you, what's the anomalies for this one? You have to say, I understand that this one can be 80% extracarpal, 20% another variation coming through the transverse carpal fascia or come through the carpal tunnel. So I have to protect it. And this is the motor supply for the hand, for the thinner eminence. If you look for the ulnar nerve, what's the important areas for the ulnar nerve? All of us, and sorry, I missed Faris' presentation, but I'm sure he discussed about the pathway of the ulnar nerve and how it goes from the arm to the forearm. What's the importance? I will not speak about where it can be compressed, but you have to know that it's covered between the FCU and FDP. It supplies this area. And why it's important? Because the level of injury. If you look at the diagram here, there's a dorsal branch of the ulnar nerve. If you have an injury above the dorsal branch of the ulnar nerve, then you will have loss of sensation on the dorsum of the hand. Below the dorsal branch of the ulnar nerve, then you will have a spared this one. In your clinical scenario, they will tell you patient presented with a cut wound at the wrist level. So what's the how you will assess him? If you don't mention that I will assess the patient's sensation over the ulnar area in the volar and the dorsal aspect, because I'm aware about the course of the dorsal branch of the ulnar nerve, then you don't know your anatomy. Okay. The other point for the ulnar nerve, you have to keep aware is the ulnar paradox. The higher lesion, the less deformity. Why is this one? Because the ulnar nerve supply most of the intrinsic muscles in the hand and supplies as well the little and ring finger FDP. So if you have a lower lesion, then they will have a claw hand. I don't know if my picture, you can see my picture. It's a claw hand. So the lower lesion of the ulnar nerve, the clawing of your hand will be more significant. If you go upper, more proximal lesion, then you actually damage the FDP. So you don't have the flexion tinge of the little and ring finger. So they will look normal a little bit with little flexion of the FDS. That's why you have to know your anatomy of the ulnar nerve. Posterior compartment, as we discussed, it's a superficial and deep. But what's the significant here? The significant is the radial nerve. So the radial nerve leave the arm and then leave the elbow around the head of the radius. It's split into two branches, the superficial branch of the radial nerve and the posterior interosseous, which is the deep branch. What's the clinical significance for this area? If we talk about the superficial branch, so this superficial branch goes below the brachioradialis. Why it's important? It's important in our Henry approach, which is the approach of the forearm. When you do the superficial dissection, you have to be careful because what we have in the forearm, what's named mobile wad, and this mobile wad, if you move it more radially, you will find the nerve passing underneath. If you injure this nerve, then you didn't follow the precautions of the approach. The second most important in the radial nerve is when you talk about the level of the injury. So most of us, when you see a patient with the humeral fracture or you see a patient with the elbow fracture, when you present in the meeting, you will say, oh, this patient have an intact posterior radial nerve and a posterior interosseous. How did you differentiate? You differentiate between the extensors of the fingers and extensors of the wrist. So if they ask you in a clinical scenario, this is a patient who came in with a cut wound around his elbow or around the forearm. On presentation, this patient was unable to extend the wrist, but able to extend his fingers. This means that the posterior interosseous is intact. And in your mind, when you integrate your answer, you have to differentiate between both of them. Now, in the arterial supply, two things in the arterial supply of the hand. You can easily look at the brachial artery. Sorry, I will make my phone silent. It's distracting me. And then it goes to the radial and ulnar artery. It's a very common question, and it came to me as well. Where does the common interosseous artery comes from? Keep in mind, if you look here, it comes from the ulnar artery. It's not like the nerves, one from each side. No, it comes from the ulnar artery, anterior interosseous and posterior interosseous. So what's the significance? Significance, it's mainly around the hand and the elbow. The hand and the wrist. Because they will, if they say injury to a certain level, you have to mention your Allen test and you have to be aware the blood supply of the hand comes from the radial and the ulnar in terms of the superficial and deep arches. It will come later, but I'll tell you now, the superficial arch in the palm of the hand, it comes mainly from the ulnar artery, and the deep branch comes mainly from the radial artery. Now, I will examine myself. I will say, this is a case, I am the candidate, and so this is the correlation where we will discuss. And I will stop here. If someone wants to ask after this one quickly, I'm happy to answer. So this is a 34-year-old gentleman presented to the ED after RTC with a closed isolated injury of the forearm. His hand was entrapped under the seat for 20 minutes. How you will approach this patient? For me, when someone give me this question, and they will not give you the X-ray first, so this is a high energy trauma. I will go to assess this patient according to the ATLS protocol. I'm assuming if this is an isolated injury of the forearm, then I will start assessing this patient clinically. From my view, if the hand is deformed, then definitely there's an underlying fracture. What things I need to exclude is the nerve injury, vascular injury, and open fractures. But first, I will give him a proper analgesia, support him with a provisional support, and then I'll start my assessment. I will request him my X-rays. In my assessment, I will assess the neurovascular structures. First, I will put my hand to feel the pulse, and on the radial side, if I can feel the underside, that's well and good. If not, then I will check the capillary filling of the hand. Mainly because I remanipulated the hand to put it in a splint. Secondly, I will exclude any open fractures. Third, I need to assess this patient in terms of the neurovascular structure. If I go to the nervous system, then I need to check the sensory and the motor. Because the patient is in severe pain, sometimes it's hard to assess the motor function, but I will assess the sensory where I will feel the radial, median, and ulnar nerve distribution. And the radial is mainly around the first web space, ulnar, median, and then ulnar on the little finger. After that, I will request him X-ray. Oh, so this is the X-rays. So from what I see here, this is an AP and a lateral X-ray for the forearm showing comminuted fracture, both bone and forearm, associated with a dislocated elbow. This is a high energy trauma. My concern in this point that this patient may be in a compartment syndrome. So I will keep him in a proper supported back slab, hand elevation. I will keep him under observation to exclude compartment syndrome. I'm aware, you don't wait the examiner to tell you, I'm aware that the compartment syndrome is mainly pain out of proportion. That's why I need to give him a controlled analgesia to avoid overriding his pain threshold. Okay, they called you back after 1 hour, you have seen this patient, and the patient is in severe pain. What you will do? I will go to assess the patient, release all the pressure sites, and explore up to the skin. So you have to mention in any assessment of a compartment syndrome, I release the back slab, keep it in place, but I release the wool and crepe up to the skin. It's very important. Then I will assess. First sign is a pain out of proportion. If the hand is tense and swollen, then this patient will need urgent fasciotomy. What do you know about the fasciotomy? And here you will speak about the compartments of the forearm. I need to release the flexor and the extensor compartment. And in terms of the flexors, there are 3 layers: superficial, intermediate, and deep. And the deep and posterior, it's mainly the extensor compartment. Do you know any approach? Then you can easily draw on yourself, or you can say it's a curved linear incision extending from the radial styloid over the flexor area, going up to the medial epicondyle. This to make sure I explore all the compartments. From the dorsal area, it's a midline incision between the radius and ulna. Do you need to release the hand? No, because the hand have 10 compartments, unless you are suspicious. Some examiners, they may want you to say, yeah, I will release the flexor compartment. That's why I will extend, the hand compartment. That's why my approach will be extended. You can. Or you can say, I will release the carpal tunnel syndrome. This scenario can go in the other way. No compartment. So what you will do for this patient? I will discuss with the patient the severity of the injury, and his elbow need to be reduced. It's a closed injury, so it can be scheduled with no neurovascular injury. I will keep him in a back slab. I will consent him and mark him for surgery to do open reduction, internal fixation. The most important thing with these severe injuries, I will inform my consultant. Guys, a lot of us have a lot of experience and they think, oh, I will deal with this patient, keep him overnight. No, you have to show your consultant you are safe. And this is the very important point, safety. After assessing this patient, this is a high energy trauma, which can go for compartment syndrome overnight at any point. I will discuss with my consultant, update him, and I will provide the patient with the full instructions. Okay, you're the operating surgeon. You took the patient to theater. What you will do? What's your approach? My approach here, it's a Voller-Henry approach. I don't think, I'm talking about Wales. I wasn't lucky as my colleagues who had the chance to get interview in England, to know more about England interview. But in Wales, it's a limited time. So they will ask you, what do you know about the Voller approach of the Henry approach? In any approach, just remember the internervous plane, which is between the radial and the median nerve. Sorry, medial. I did it 4 o'clock in the morning, that's why. Median nerve. Proximally, between the brachyradialis and pronator teres. Distally, between the brachyradialis and FCR. Yeah, but this is not the significance of this approach. You have to mention, I'm aware about this approach and between the internervous planes. The most important point, if I'm dealing with the proximal 1/3 fracture, then I need to have full supination of the forearm because this will protect my posterior interosseous. Then if I'm dealing with the middle third, I need to release the pronator teres and I need to have a full pronation. If I'm dealing with the distal third, then it will be partially supinated. So from the proximal and the middle third, I need to have these 2 points. The approach, you can read it from any book. You can say the steps because you elevate the brachyradialis and protect the superficial radial nerve as we discussed. Here is the significance of the anatomy we are talking about. Going deeper, it's very easy. Whoever have done this surgery, once you open the skin, you'll find your plane from the trauma, and then you can follow it with protecting the neurovascular structures. But the tip and tricks in every step is these points. Proximal, supination. Middle third, full pronation. And distally, partially supinated. It's mainly to protect the posterior interosseous nerve. Now, whoever have seen an X-ray for the distal radius or have studied anatomy is aware about the anatomy of the distal radius. Where is the radial styloid? Where is the ulnar styloid? The TFCC? Where's the listed tubercle? And the clinical significance of the radial styloid to have the scaphoid fossa and the lunate fossa, the articulation of the distal radio-ulnar joint. I will not run through these parts, but what you need to know from this part related to our scenarios is this one. Distal radius is a very common fracture, common question for distal radius fractures. The things you need to keep in mind is how you assess these patients in A&E. And they will bring you an X-ray for the distal radius. What are the parameters you are using to assess, is it acceptable or not acceptable? And every time with practice, you will get used to fixed numbers in your mind. So I fix the radial inclination is 20 degrees. Radial shortening is 10 and volar tilt is 10. But actually the true numbers are radial inclination is 23. And if you take 13 out of it, which is the radial shortening, then it's 10 for the volar tilt. Radial inclination and radial shortening, you can see them on the AP view. In the volar tilt, whereas the inclination of the dorsal aspect with the dorsal rim and the volar rim with a 90 degree of the mechanical axis, this is on the lateral view. So why they will say, you can easily say why it's not acceptable. For example, if you lose the volar tilt, then the patient will lose the flexion of the wrist. If you lose the radial shortening or the radial inclination, then there will be a radial drift and deformity of the wrist, and you will lose sometimes the power, the grip of your hand. Carpal bones. Carpal bones, 8 carpal bones, articulating into 4 proximal and 4 distal carpal bones. What's the significance here? Significance is scaphoid and lunate. What they can ask you for the scaphoid and lunate, scaphoid is falling an outstretched hand in extension area, in extended position. It causes high axial compression on the scaphoid, affect cause fractures. So what's the anatomical importance of the scaphoid? It's the blood supply, and it's supplied from distal to proximal. That's why the proximal injuries of the scaphoid is less in rate of union. Waist is acceptable, distal pool higher rate of union. Okay, what's the important again of the scaphoid? The scaphoid is the only bone which articulates the proximal and the distal rows of the carpal bones. That's why if you have any fracture scaphoid, then it can easily dissociate the link between both of them. Later on, it will cause malalignment, and later on will cause deformities in forms. I don't want you to go for this, but this is something very advanced, which is BZ and VZ. Based on that, we have to keep close observation of our scaphoid. For that, we need to understand what's anatomical snuff box. Anatomical snuff box, it's a space around the wrist, mainly at the bottom of the thumb, a proximal area of the thumb, around the wrist. The floor of it, it's formed by the scaphoid. And if it comes to the anatomical, for the clinical correlation, if any patient turns up with, after trauma, with a pain over the scaphoid, then high risk of scaphoid. So what high risk of scaphoid fracture? So what's the importance here is X-rays of the scaphoid in the first 2 weeks, it can be missed. So if a scenario gives you 20 years old gentleman who was playing football, fell on his hand, he's very tender around his wrist, around the snuff box, how you will assess him? I will examine this patient, assess his neurovascular status. My concern at this area is possibility of a scaphoid fracture. Based on that, I need to examine the hand, mainly around the snuff box, as the snuff box is, the floor of the snuff box is formed by the scaphoid, and I need to palpate the scaphoid tubercle, which is in the volar aspect here. Based on my clinical assessment, I will request the X-ray of the wrist, and there's a scaphoid view. Sorry, I didn't wrote it here, but I can bring it later. So they will give you X-ray normal. And from the X-rays normal, you will say, I'm still concerned about the scaphoid. High percentage of scaphoid fractures can be missed on a provisional X-rays. For that, I will keep him in a plaster and see him back again in clinic in 2 weeks to repeat the X-rays out of the plaster. This is the significance of the scaphoid. What else can be significant in the snuff box is the component, because the superficial branch of the radial nerve is there and the radial artery is in the snuff box. So any cut wound injury, it will be high bleeder. Just keep it in your anatomy revision. Going back again to the carpal bones, we have important part in the carpal bones is the glula lines. Glula lines are 3 lines, arc 1, 2, 3, as you see in pictures, and they should be all smooth, well, with no overriding. What's the importance? It gives you a hint about X-ray, about the alignment of the carpal bones. I'll skip this and come back again for it. See this one. I will break it for each case because I have 10 minutes. I don't want to be late. So if you look at this scenario, 25 years old gentleman presented with a severe wrist pain, numbness after falling on an extended wrist while playing rugby. So this is falling on an outstretched hand. I will go to assist this patient, keeping in mind he's having numbness. I will ask the patient about his hand dominance, smoking, and any other medical comorbidities which can affect the patient. As diabetes, he may have a peripheral neuropathy, but this is something irrelevant if you give you older age or have other anomalies. Then based on my assessment, I will assess median ulnar and radial nerve. Oh, the patient have a distribution of numbness in the radial 3.5 fingers. So my concern at this point that this patient had an injury of the wrist, which is affecting median nerve. I need to have an X-ray. Oh, they give you this X-ray. Looking at this X-ray, this is an AP. I will need a lateral view of the X-rays to assess the proper alignment. But from what I'm seeing here, there's a loss of glula lines. Can I have a lateral view? Yeah, this is the lateral view. So what you can see on the X-rays, there's a lunate dislocation. And this is counted as one of the emergencies, especially with the median nerve compression. On the AP view, you can see piece of a pi sign, which if you look here, can you see my cursor? This part. So the lunate move and it gives you like a part of a pizza or part of a pie. Then if you look at the lateral, the lunate should be facing forward and now it's have slipped teacup sign. What you will do for this case? In this case, with an emergency of the pressure on the median nerve, I will discuss with my colleagues in A&E to have a regional anesthesia or sedate him, and I will need to attempt manipulation of the hand. Are you aware of manipulation? How technique? Technique for these cases are with the traction and counter traction around 15 minutes. I need to maintain this between 10 to 15 minutes to relax the soft tissues, and then hyperextension followed by forward flexion, pressure on the lunate to bring it back. There is a risk that this patient may not be reduced. So I need to discuss it with the patient as he may need to go to theater. After manipulation, I will keep him in a flexed position to relax and decompress the median nerve. And based on that, I will re-X-ray. Oh, so he had an X-ray. Still, the wrist is not reduced. The lunate is not reduced. I'll discuss with my consultant because this patient will need urgent surgical intervention. I will keep him nail by mouth. I will consent him for open reduction with internal fixation, plus or minus median nerve exploration. And I will keep him ready for surgery. I will inform my anesthetist and I will inform my consultant to prepare everything for him. You have to be safe. All of us can say the same words. Going back, for the wrist, what you need to know about the wrist. Most questions are around carpal tunnel. And what you need to be aware of, what are the structures passing under the transverse carpal ligament, and what are the structures not included in it. So what is inside the carpal tunnel? You have FDS, FDP, and you have a flexor pollicis longus. These are the most important structures. Some of them, they say there's a palmaris longus, but it's not true. Palmaris is outside. Then you have the flexor carpi radialis outside. Is the ulnar nerve around the Guy's canal passing below this? No, it's superficial. So ulnar nerve is not under the transverse carpal ligament. What's the significance? When you do a carpal tunnel release. Again, with a carpal tunnel release, you have to keep in mind with the abnormal presentation of the median nerve in terms of the recurrent motor branch. Extensor compartment. This is something you need to memorize. I can't make it easier. There are 6 compartments, 1 and 2 beside the lesser tubercle, radial to the lesser tubercle, and the rest of it, it's ulnar side. And you need to know each compartment, what does it have? Why? Because you have a Dicker van, they can easily bring you a scenario of a Dicker van in the first compartment, and they will ask you, what are you releasing? And how you can do this one. Second, it's not common, but it may turns up. The third compartment, it's very common question with the radial nerve, with the distal radius fracture and plaster with a patient unable to extend the thumb after 6 weeks of injury. Now, this is another scenario. I will bring it up quickly. 40 years old, fell out of stretched hand. How you approach this patient? I will go to assess this patient. I will do clinical neurovascular status examination, and then I will assess median ulnar and radial nerve. You have to mention that you have assessed them. I will exclude elbow injury, especially with the playing football. I will exclude if any associated elbow injuries. Then I'll do him an X-ray. So this is the X-rays you have. According to the available X-rays, so the patient actually lost the parameters of the distal radius, which is acceptable. So he lost his radial inclination, lost radial shortening. He have a radial shortening, and the volar tilt, it's now dorsal tilt. So this is unacceptable position. I will discuss with the patient option of manipulation. I will discuss with my colleagues in A&E, give him provisional regional anesthesia or Pentrox, if whatever you can do it. Keep in mind, you have to be reliable and say what you are doing in A&E. I provide patients with a Pentrox and do manipulation, intrahematomal block, I do manipulation, regional anesthesia, do manipulation. I will do manipulation in a way of traction and counter traction and volar tilt. And according to the boost guidelines, these patients need to be in a neutral position, no need to do a hyperflexion or hyperextension. I will keep him in a plaster, check X-ray. If it's acceptable, according to the guidelines, fracture guidelines, these patients need to be seen in 72 hours. It's very simple. You have to show that you're safe, smooth, and follow the protocols. Okay, patient turned up again in clinic, displaced. You are planning to do a surgery. What do you want to do? So you need to be aware of the FCR approach, flexocardialis approach. This is the approach to explore the distal radius. And in this approach, you have to say, patient will be consented, signed, supine, tourniquet applied, and I will do the WHO check, WHO checking in theater, confirming the site and the site of surgery. Then the approach will be along the FCR tendon, extending toward the mid forearm. Superficial, I'm not convinced, but I'm not the anatomical or the surgeon. This is not counted as internervous plane because you take the FCR ulnar and you will be between the FCR and the radial artery mainly. If there's palmaris, then it's palmaris, but I don't think so. And you have to mention, I'll detach the pronator quadratus and explore the fracture site. What are the risks of injury here? Is the radial artery and the palmar-cutaneous nerve of forearm. Again, in any approach, keep your mind systematic. I need to be between 1, 2, go deeper, open the fascia. I can tell you the approach in 30 minutes alone, in layer by layer, but I'm giving you the tip and tricks for each approach. I will skip this scenario because I want to give you the next one. Now, for the hand, I don't need to go much in the bony structure of the hand and the muscles of the hand. You need to memorize it properly. The thinner, hypothinner, intrinsics, lumbricals, and the interossei with the function. And how you have to know how the flexor, the FDP and FDS works around this area. So the hand is zones, zone 1, 2, and 3, and 4. but this is very high question because it's mainly plastics or mainly the hand specialist. Any injury for these areas, then they have to have a certain way of reconstruction. It's not this topic I'm going to talk about. The blood supply, superficial and deep branches. As we said, the superficial is mainly ulnar and the deep is mainly radial. Now, this is what I need to speak about. The synovial sheath around the flexor tendons. The synovial sheath is in the index, middle, and ring fingers. They are mainly located for the flexor tendons. In the little and the thumb, they can extend up to the wrist, and they can cause what's named horseshoe lesion, because if they are linked together. So what's the significance of this one? It will come as a flexor sheath infection. I will give it as a case. It's better to explain it. So this is a 42-year-old gentleman who's an IVD drug user, presented to the ED with a 2 days history of a severe pain and swelling in his right index finger. He stated that he cut on a piece of metal and its condition has been worsening since. His inflammatory markers are elevated. How you can approach this patient. So according to what I'm seeing, this is a clinical photography of a right hand showing a cut wound in the volar aspect of the index finger at the level of the DIP joint, associated with marking all around the thinner and mid of the palm. There's a redness, swelling of the finger extending down to the palm. According to the history, this patient is not feeling well with severe pain. So this is a clinical important. In my mind, I need to exclude the infection. And in this area, you have to mention that flexor sheath infection is one of the most things I need to exclude it. Based on that, I will go and assess the patient. First, I will take his vitals, check his temperature, heart rate to see if he's septic or not. Second, I will do assessment in terms of Canaval signs. So what are the Canaval signs? Sorry. There are 4 signs. The finger is a fusiform. If you look at the index, it's a fusiform compared to the other fingers. Then it goes in the resting position, which is a flexion position. And if you palpate all the flexor tendons, they are in severe pain. And if you try to extend them, it's horrible pain. Based on these signs, this patient have a signs of flexor sheath infection. So I will start approaching this patient by doing full bloods. And according to the question, it says high inflammatory markers, hand elevation, support. I will take a blood cultures. I will start IV antibiotics according to my hospital guidelines. I'm aware that the most common organism in these cases are Staph aureus, but I will check my hospital guidelines. I will inform my consultant because this is accounted as an emergency. The patient may need to go to surgery overnight. I'm aware of the technique of this, how to do the washouts. There are 2 ways of doing the washouts. One of them is doing minimal approach, longitudinal incision at A1 pulley, and longitudinal incision where the skin cut there, and insert vent flow, wash all the synovial sheath from proximal to distal. And the second way is full exploration, doing a Brunner approach. The patient will be, and if he asks you for the approach, then you have to mention about consent and everything. It's a big topic. I know I can't cover everything, so I tried to be to the clinical significance mainly. I'm happy to answer any question.
Mamdouh, thank you so much. I think there is a couple of questions in the chat.
Yeah.
Ahmed is asking you to repeat the forearm fasciotomies.
Yeah. So, Now, Ahmed, are you online with me? Do you hear me?
Yeah.
So what's your question here is how you do the fasciotomy, yeah?
Yes.
Okay. Now, the fasciotomy in any compartment syndrome, what you need to do is to release the compartments, yeah?
Yeah.
So it's a curved linear incision extending. If you look here, if you look at the literature, actually, you will find different diagrams. But the safest one is like a lazy S incision. Start from the radial styloid, taking to the mid forearm, extending up to the medial compartment. So you can raise up flaps. Once you raise up the flaps, you release all the superficial and deep and middle compartment. It's old idea about you release the compartment. Some people do it like a Henry approach, extended Henry approach, go up. If you mention, I need to release the compartments of the forearm in terms of superficial, deep, and intermediate by curved linear incision, it's more than enough. And don't forget there's an extensor compartment. It's a straight line incision because all the muscles are in one layer. You're allowing the muscles to breathe.
Okay, perfect. Thank you.
What other questions? Sorry, I can't see the...
So it seems about the case.
Which case?
Yeah. So will you reduce the elbow? Yeah, I think this case.
Yeah. You would not leave it dislocated. Yeah. No, in actual life, it's hard to reduce the elbow. It will be done during the procedure.
May I ask something, please?
Yeah, sure.
So is this regarding this elbow dislocation associated with postbone arm fracture? Well, I did actually face that last week. Well, I find too helpful. Try to put a blue elbow back slab and try to push the elbow after doing that. It came back easily. I'm not sure if because of the...
Yeah, it depends on... See, you can do anything, but sometimes it's... If you take the patient to theaters straight ahead, then you will take him to theater, do the surgery. It's this is the only picture I found yesterday, late during night, so with a severe comminution.
Yeah, I totally agree. But the issue is, I'm not sure if it came back because I did a good job or because just was a coronoid fracture and
No,
the
because you did a great job. No, because you did a great job.
I don't think so.
So,
this patient will not go to theater on the very same day usually. What was the timeline? I'm really interested about.
If the patient turns up at midnight, at 2-3 o'clock in the morning, then the patient will be first on the list for next day. If the patient turns up at 2 o'clock, so this is a very good question. If whenever they are asking you the question, keep in mind you have to be sensible to time. So if the patient turns up at midday with this severe injury, high risk of compartment syndrome, and there's a risk of neurovascular injury, patient is fasting, had last thing to eat at 8 o'clock in the morning, and you saw him 12 o'clock. So you can easily take this patient. It depends on your hospital. It depends on your location. But if you say, I'm well prepared to do the surgery because it's a fracture dislocation, I need to reduce everything together. Sometimes it's very hard in A&E. And I faced a case like this, I couldn't reduce the elbow.
I agree. Great, thank you.
Can I ask a quick one, please?
Yeah, sure. Any question?
Yeah, so regarding the scaphoid fracture, there's two questions actually. So usually what we do in the ED, immobilize do a scaphoid cost, but I read that we should put it in a standard back slab because it encloses the thumb and distracts the movement heavily.
I don't remember, the paper is not on top of my mind now, but if anyone upper limb surgeon here can help, there's no clinical significance between a scaphoid plaster and a normal neutral plaster now in managing of the scaphoid fractures.
Okay, so should I go to the normal back slab?
Neutral volar back slab, volar slab or back slab, whatever your protocol.
Okay, another question regarding the scaphoid. I read also before that it should be in acute settings. It should be above elbow back slab because to restrict the pronation and supination.
There was another study showed as well I don't remember the names, but there was no difference between above and below elbow. Because I had the same discussion with my hand consultants like 2 years or 3 years ago, and they showed me the papers. There's no significance between these two. The only point they may do is if you say in A&E, if there's a high suspicion of a scaphoid with the hand swelling and that, they do an MRI scan. So the new recommendation, it depends on your hospital policy, is to do an MRI scan from the A&E and a patient to be seen in acute setting in the clinic with an MRI scan if there's a high suspicion. If there's no high suspicion, then you do a normal protocol. You bring back again the patient in a week to assess him. If it's still tender, you keep him in a plaster, bring him back again in 1 week, and you will do an X-ray out of plaster when he turned back again in 2 weeks. In 2 weeks' time, due to the vascularity of the fracture site, you see like a line extending there.
Okay, so just to double check, so just keep him in a neutral back slab below elbow in the
Below
acute
elbow. Yeah,
settings.
yeah,
Okay,
yeah.
all right. Thank you.
محمد شيال.
Yeah. Well done, Duha.
Mr. Shayal, how are you doing?
Yeah. So my question is, if we have a case with perilunar fracture dislocation coming overnight with
Yeah,
sensory deficit, is
yeah.
it it's a good time to take it to theater or wait in the morning? Other questions. If we are planning to do open reduction for it, is it mandatory to do carpal tunnel decompression as well or not mandate?
Okay.
Thank you, Duha.
So in the first question, this patient, the pressure on the nerve at the moment, because it's not acute cut of the nerve, so it's a neuropraxia. The longer time you keep the nerve under pressure, then the more damage is going to happen in the sensory deficit area, in the median nerve. You have to give this patient a trial of manipulation. Either you do it down in A&E, or if your consultant is happy, you can do it up in theaters. Again, in A&E, you can do it by yourself, but you have to have a good team helping you for traction and counter traction. If you take a patient to theater, then you have to follow the safety protocol, which is I will inform my consultant for as this patient need manipulation and he's nail by mouth. There's a sensory deficit. I will try to take him to theater to give him anesthesia, do a manipulation, and then if it comes back, comes back. Now, when you can do this one, you can do this one if you are in a hospital with no hand team, and if the wrist doesn't come back again, you will transfer him anyway to another hospital. Or if you don't have a hand surgeon, or your consultant is a hand surgeon who said, do a manipulation, do a C-arm. If the hand doesn't come, we will open it. Or if your consultant is happy to open it. Safety is the most important thing. I faced similar case. Patient turned up at 3 o'clock or 4 o'clock in the morning with leonate dislocation. I tried to manipulate it once in A&E. It didn't came back. My consultant, this was like 5 o'clock in the morning. My consultant said, keep him hand elevated. We'll do him in the morning. It's fine. This is my consultant decision. It's my responsibility to update the safety measures here.
Sorry, Duha, but you call him in the middle of night?
I will call him in the middle of night.
Yeah, thank you.
I will inform my consultant. So keep in mind, some cases you need to call your consultant anytime. One of them is a supracondylar fracture humerus with neurovascular injury, leonate with a nerve injury, native dislocation with a neurovascular injury. So these are important, and necrotizing fasciitis as well.
Perfect, Mamdouh. Thank you so much.
Thank you, Duha.
Really appreciated this. Yeah, very thorough. Good. So time to go to Paeds. So, Muhammad Khalifa, you can share your
Do you
screen.
need Dr. Hashim, do you need this slide at the end? I don't know if this.
I have it, yeah.
You had it?
The one you sent me, yeah.
No,
Yeah.
this.
Yeah. And at the end of the mock as well.
Okay.
Thanks, Mamdouh.
Thank you, everyone. Stop sharing.
I will share the screen in a sec. 1 second.
Yeah.
Can everyone see the share screen now?
Yeah, just if you make it slide share, Hamad, we see it. Perfect.
Slide share now. Okay.
Yeah, perfect. Yeah.
Okay, good afternoon. So we're back again for another session. So this time we're going to talk about Paeds. It does have a bit of flavor around hips as well because the hip problems are common in Paeds. So this is a quick outline of the topics we're going to talk about. Again, same as yesterday, bit of anatomy, some guidelines, approaches, operations, and some clinical stations at the end. Just before we start Paeds, in Paeds, again, similar to spines, the knowledge bit might not be as not much required in depth as other specialties, but they will assess you for two things. One, safety. You're safe when dealing with kids. And two, common sense. Again, you deal with them with what you think it is. So safety and common sense. Okay. So just keep this in mind rather than focusing on too much knowledge. So if we start by anatomy, again, femoral head anatomy, blood supply. Again, this is similar to what we discussed in the hip. What you need to know in children below the age of 4, it's the other way around. So lateral circumflex have more contribution, and you still got some contribution from the obturator vessels. So they have a bit of contribution. After the age of 4, they reverse to the adult pattern, and by the time they are adolescents, like 12 years and more, they can be same as the adults. Just be aware of here, you see this vessels, the lateral cervical ascending we mentioned yesterday in children, it's very close to the piriformis fossa, and that's why we try to avoid piriformis entry nails, because it can cause AVN of the femoral head. So if you have to use nails in children for femur fractures, for example, it has to be a trochanteric entry, or you can use physeal sparing by going through the medullary canal with the elastic nails. So that's the clinical relevance of it. This thing, I've added it because it's quite topical. When you read an X-ray of a skeletally immature, this is very common. Medical student, registrars, etc. should know it, which is you can call it crimptal or cretal or crato. So basically, you start with the capitellum, radial head, and then internal epicondyle or medial epicondyle, trochlea, olecranon. You can't see it here, it's there, but you can better see it on the lateral, and then the lateral epicondyle or external epicondyle. So this is the last. So 1, 3, 5, 7, 9, 11. You can do it odd numbers or even numbers, and you add 2. So this is the order of ossification. So if you see a child who's 3 years old, for example, you will only have the capitellum and the radial head. You can't see the rest. So the clinical importance, for example, if you see a child, like for example, 5 years old, so it should be CRM, and you can't see the medial epicondyle, then mean that this medial epicondyle is fractured and dislocated and displaced, which is one of the fractures. So just be aware of that when you look at things. Okay. Again, bit of anatomy. You need to know about the differences between adult and children's skeleton. You've got the physis, which is the growing cartilage. And again, you can have injuries around the physis. The commonest is Salter-Harris classification. A mnemonic is called Salter. So type 1 is straight across. If you have a bit of above, the Thurston Holland, there's one. So it's called above, this type 2. Below, which is an articular fracture, is number 3. Through or 2 would be number 4. And ER, which is number 5, complete erasure or complete damage of the physis. And as a rule of thumb, 1 and 2, you can treat them usually non-operatively. You have to reduce them. All physeal fracture has to be reduced, but These one are extra articular, so you can put them in a cast and reduce them. 3 and 4, because they involve the articular surface, most likely will need some sort of operative intervention because you need articular reduction, anatomic and rigid fixation. A special subtype, this might be FRCS level, but when you come to the ankle around the age of the adolescence, between 12 and 15, the physis start to close from the medial side, then goes anterior and posterior, and then goes to the central part, and then closes lateral at the last. So when they fracture, they get this weird pattern. You can say it's a Salter-Harris 3 at the AP, and Salter-Harris maybe 2 or 4 on the lateral. So it's quite confusing. That's because it's called a triplane fracture. This is how the fracture goes. So it goes into 3 different planes, as evident by this diagram here. Just to be aware of, I don't think on ST3 level they ask you that deep. Okay, that's enough with anatomy. We'll go now to the post guidance, and this is the Bible of the pediatric injuries. I mean, when I asked a consultant to do a mock exam for me, ST3, long time ago, he just didn't think. He just gave me a scenario of supracondylar fracture. I mean, they love it. Lots of things and lots of things to pick up good candidate versus not so good candidate, okay? So first of all, it has to be documented pre-op. And you have to document carefully few things. 1, the pulse, the radial pulse. 2, the capillary fill. And 3, the individual nerves. You don't just say, I will do a neurovascular examination. This will fail you. You have to say specifically what you're going to look for. Radial pulse, capillary fill, and individual nerves. And again, remember, there are children, okay? So you have to find something easy, and you have to appear slick, as you've done this before. So sensation, you can ask older children perhaps to do to feel some sensation, but they will, in real life, they will be in a lot of pain, they are afraid, so might not be reliable. Motor function, again, you can say rock, paper, scissors, okay sign. Again, you don't say, okay, now do this, do that. So you just tell them something is easy for 5 years old to do. So rock, median, radial, ulnar, anterior interosseous. Sometimes I say instead of doing anterior interosseous, just imagine you're playing Xbox or Nintendo or something, so do this or do that. So similar. So you just tell them something that they can follow and also make it a bit funny for them. So that's so remember the areas of the skin and also for the, and then if it is displaced supracondylar, you have to operate. We'll come to supracondylar later. But when do you operate? They will try to catch you on this. They'll say, would you take him now, take him later? It's 10 in the evening, it's 5 in the evening. So the guidance is clear on the day of injury. So if you see him at 5 p.m., you operate on the same day. Nighttime is not necessarily, unless there is an urgent indication. And again, nighttime is a bit vague. Most of the hospital, they say maybe till 10 p.m. Some surgeons or some consultant would say up to midnight. Beyond midnight, probably you should not operate unless it's urgent. But even if there's no urgent indication and they come at 4 p.m. or come at 3 p.m., 5 p.m., you still operate on the same day. Urgent indication, this has to go theaters immediately, okay? So absent radial pulse, regardless whether the limb is perfused or not, if it's pink or pale. Signs of impaired perfusion, so if it's cold or delayed capillary fill, even if there's pulse, but it looks not well perfused. Open injury, obviously, and threaten the skin. Okay, so these are the indications. You have to know that most of these is not because of the artery is torn. No, it's because everything is kinked or spastic. So once you reduce the fracture, you should restore the vascularity. And that's why we should do the operation as soon as possible. So if there is no signs of ischemia after you reduce it, there is no need for exploration. So if there is no pulse, if it's pale, if it's cold, etc., and you reduced it and it's pink and you've got pulse, no need to explore, okay? And then when you fix it, don't try to reinvent the wheel. They said, give it to you. 2 wires, at least, with 2 millimeter thickness. You have to engage the cortex, not intramedullary. It has to go into the cortex above the fracture site. The better is to use crossed wire. And again, I've done supracondylars here. I would say 90% of people would prefer to do crossed wire, medial and lateral, because it's biomechanically stable, but has got risk to injure ulnar nerve. If you do a lateral wires, they have to be divergent, again, minimum of 2, but most people will put 3, because biomechanically 3 wires laterally is as stable as crossed wires, okay? And if you do the medial wire, they don't say don't do it, you do it, but you have to document what did you do to prevent ulnar nerve injury. So basically, you extend the elbow to stop, to move the ulnar nerve away. You have to open it, not percutaneous. A mini open incision, you have to move away the ulnar nerve and use a drill sleeve. You should use the drill sleeve for the drilling, and you put the wire through it, and you put. So you have to show them that you have done this before, or at least you are aware of it. So when to explore? Do you explore after you reduce it, happy with it, and you still the limb is ischemic? Then yes, this is indication now that there might be a problem with the vessels. So the vascular team has to be aware. So any pulseless limb or ischemic limb, even if they're not going to explore, you inform vascular at the beginning. Tell them be on standby. They come in if after the reduction it's not still sufficient. Okay, and then you have to monitor post-operatively. Usually you will monitor for two things: vascularity and compartment syndrome, at least 24 hours. If you damage the nerve post-operatively, you have to document it. And you do nerve exploration plus minus after you discuss with the peripheral nerve surgeon. Okay, and the nerves you check post-operatively are the same three nerves: the median with the anterior interosseous branch, radial, and ulnar. They can all get injured. The commonest with the operation is the ulnar. The commonest from the injury itself is the median and the anterior interosseous. Radial is a bit rare, but can also be damaged. Compartment syndrome, again, you have to manage according to the compartment syndrome guidelines, so immediate assessment and intervention. And if you do a brachial artery exploration and revascularization, they might do a prophylactic fasciotomy from the beginning. Okay? And then what is the follow-up? You follow them 1 week to check the wound, to make sure that the wires hasn't moved, and to get an x-ray. And then you put them back in a back slab for another 3 to 4 weeks. No longer than that. There is no 6 weeks. It's just 3 to 4 weeks maximum. And then you have to remove the wires. It might debate to remove it in clinic, remove it in theaters. Just say what you would normally do. No one will argue with that. But most hospitals would remove them in clinic unless parents make a fuss and they want it to be removed in theaters, or the wires are buried and you can't take them out. No long-term follow-up, no specific physio. Kids will recover very nicely. Okay, but you can mention if you know something from your own hospital, you can mention it as well. But don't be controversial. Just stick to the guidelines. There are other two boasts with children. One is about infection. You will get it probably in a limping child, or a child has got some sort of infection. And there is one which is a bit new about forearm fracture, how to reduce them and manage with them. So again, if a children, ideally, you should be treated in the hospital near them. But if it's a complex case, it might be need to refer to a tertiary center within 24 hours. But they will present to your local hospital. You have to document history and examination, head-to-toe examination of a child to look for source of infection, limbs, joints, spine, and any systemic source of infection, chest infection, for example. You have to document the vital signs and to do the weight-bearing status. And the care has to be joined between orthopedics and pediatric teams together. And then you have to do biomechanical and radiological investigations. So FBC, ESR, CRP, blood cultures, they say it had to be at least 2 mils of blood cultures. And you get a plain orthogonal views of the joint infected. Suspected hips, for example, you get a pelvic X-ray, AP, and frog lateral, or depending on the joint. Do we need further investigation? In some cases, if the diagnosis is doubtful, you can get MRI as a second line within 24 hours. But sometimes, if it's not feasible, or if it required more urgently, you can get an ultrasound. For example, you can get hip ultrasound, for example. But again, the problem, it needs an MSK, a pediatric MSK radiology consultant, which might not be available. Same with the MRI scan, but at least MRI scan, you can look at the scans yourself till an MSK radiologist can report it. And they can report it remotely as well. They don't even in hospital. So depending on your hospital. Again, if sepsis, don't forget sepsis 6. And there's also a nice guidelines for sepsis under 5. So you can look at that, what to do. And you should, once you take your samples, you can give empirical IV antibiotics. If patient is stable, again, he's got limping, maybe high CRP, but no fever, and not unwell, vital signs, you can leave antibiotics till you find out what's going on. Again, if it's septic arthritis, this is surgical emergency. You have to drain it. And this will take you to the Smith-Peterson approach we discussed yesterday for a hip septic arthritis. So that's one thing. And it should be done ASAP, but maximum 24 hours. Again, you make sure that you've got a surgeon who can do that. If it's osteomyelitis, pyomyositis, which is like psoas abscess, or discitis, these are the other differentials of infection in children. the treatment is IV antibiotics, not surgery. Surgery only if there's an abscess cavity, or if you cannot sample the infection and you need to have an infection. For example, blood cultures are negative. Okay, and these patients would need a PICC line. So when you mention PICC line, you give them the cherry on top. Tell them that you know that they will require maybe a couple of weeks antibiotics, and you don't want to struggle with cannulas. So give you extra points. And then when to stop antibiotics, again, there are different policies. There is a paper from the Birmingham Children's Hospital. They said the short course antibiotic is suffice, but the general guidance is you look for temperature. So once they are afebrile, CRP is going down, ESR is going down, white cell count going down, and the kid clinically is lively, he's getting out of bed, he's walking, you can stop IVs and convert to orals. This can be as short as 3 to 5 days in this Birmingham study. But most of the safe practice would be 2 weeks IVs and then oral depending on. But it can be as short as 3 to 5 days, or as long as quickly as they get these clinical parameters improved. And then you follow them up to 12 months. Why? Because you're worried about AVN of the hip, for example, you're worried about septic arthritis sequelae or recurrence of infection. So the infection recurrence or sequelae of infection. So this is why you follow them up at least for a year. Forearm fracture, again, similar as any displaced fractures. So they will say, but the key thing here is the guidance from both to avoid admission. A child who is like a simple both bone fracture or distal radius fracture does not need hospital admission. So it's not something new you would do if you do it in A&E. Okay, so feel confident with that. The guidance say you should do early definitive manipulation without admission. Okay, so the hospital should have a procedure for analgesia, sedation, and timely response. Okay, again, depends on the hospital, but the current guidance pushing this to be done in ED or in a safe place for children to minimize admission. Again, same as the supracondylar, you document radial pulse, capillary fill, individual nerves. They should have effective analgesia, pain scores, orthogonal x-rays. You get a formal consent from the children and their parents. So if the child is old enough, Gillick competent, they can sign, but otherwise from the parents. And then you should manipulate. They didn't specify. They said a safe place. You should have monitoring, casting facilities, and managing complication and recovery from medications. It has to be a competent orthopedic practitioner, which is yourself, and orthogonal views and neurovascular status after reduction. Again, they should be provided with analgesia to go home with and red flag leaflet to tell them what to do, safety net. And then you should see them within a week in clinic, and then a consultant review within 48 hours to see what you've done, to criticize your handiwork and make sure that these patients will get followed up later on. So can be in the trauma meeting a couple of days after that, or usually the next day. Okay, so these are the guidelines, nice and easy. Approaches, nothing. I mean, we discussed the Smith Peat yesterday, so you can go back to the hip. And remember this spiel you say about every approach. The indication, positioning, surface marking, intermuscular plane, internervous plane, structures at risk. Yeah, make it slick and make it look you've done it before. Right, operations again. This is now, they would probably need you to know about supracondylar fractures a little bit. It's more common in FRCS, but you should know some about it as well. So Gartland classification, this is when we mentioned about it. So undisplaced type 1, displaced but still in contact, angulated type 2. Type 3, this is most of the stations will come like that, which this one would need operative, and this is one you would worry about the vascularity. Type 4 is complete, so it can go either flexion, extension. So this is extension type, which is the commonest, 90% to 95% of the cases, and this is Gartland classification. Okay, so when you describe the X-ray in the station, you can say this is an extension type supracondylar displaced type 3, for example. This will give you extra point. Again, how to reduce it? First of all, you would mention everything about appropriately marked, consented, WHO checklisted. You've done the WHO checklist, prophylactic antibiotic, etc. So you have to do sustained traction. The key is sustained traction, and the elbow is less than full extension. If you pull it in full extension, you will increase the deformity. But if you want to pull in the line of the humerus, it should be about 10. It also helps to relax the brachialis muscle, so it helps you to reduce it. If it's full extension, the brachialis is very tight and you can't reduce it. So 10 degrees, 10 minutes. or 5 minutes. 10 minutes is too much, but probably it's about 5 minutes. If you see this sign, so anterior ecchymosis and brachialis, what called puckering, this means that it will need those 5-10 minutes really. So don't go too quickly. You can use this milking maneuver. You put your finger in your thumb and you try to milk it down to try to ease the fragments. And then once you restore the length, now you correct what we call the coronal deformity. So you move it in between varus and valgus, between your thumbs, and try to correct it. And then once you achieve that, you put your thumb at the back because it's extension type, flex it, and then you pronate it. This is you will lock the elbow. And if you get an X-ray in this view, it's called Jones view. So this, how to achieve the reduction? So olecranon fossa falling together. You look at the columns, matching columns. There is no overlap of the fracture site. So this is all good. This means that you've got good reduction. Lateral is a bit more tricky. So this is the anterior humeral line, should go through the middle of the capitellum. If it's below that, this is still not reduced. You make sure that it's flexed about 25 degrees. This is the normal relationship of the distal humerus. You get this hourglass sign or teardrop. This means that you've got perfect reduction. And this one is when you look at the AP, it's called the Bowman's angle. It's about 70 to 80 degrees, which you can see it here. But it's a bit difficult. So if you just stick to those X-ray views, they are enough. That's about it really. And then the fixation, as discussed before, you can put either crossed wires or you put 3 diversion wires. And then you say, I will put the lateral wire first, achieve stability, and then you put the medial wire. Why is that? Because you need to extend the elbow to prevent the medial nerve, the ulnar nerve injury. So if you extend the elbow without a wire, then you will lose reduction. So that's why you put the lateral wire first. And again, you say the 2 millimeter crossing 2 cortices, proximal and distal, okay? And it should be well above the fracture size. So it should be engaging the lateral and medial cortex, the columns itself. They might ask you, how would you reduce in ED a forearm fracture or a distal radius fracture? Again, if you get that, again, you should tell them give them a flavor. We've done this before. So you need, again, according to the guidance, to be done in a safe place, competent team. So you should have at least you, and you have somebody who will monitor the sedation, analgesia, usually an anesthetic or an ED doctor. And then you should have an assistant to do the counter traction, and another one to put the plaster, a plaster technician or a senior nurse, for example. So a minimum of 3 people, okay? So one is pulling, one is counter pulling, and one is putting the plaster, okay? If it's a distal radius, and if it looks off-ended, you just tell them you might need to exaggerate the deformity to get it across the fracture side, and then you reduce it again by, if it's dorsally displaced, you put it in a volar direction. When you pull from the thumb. This will help to correct the radial deviation of the injury, and you will get into ulnar deviation. In the forearm, again, similar. You might need to exaggerate the deformity first and to hitch it, and then you straighten the limb again. And then this is the key thing. When you do the plaster, it has to have 3-point fixation. So the distal radius, for example, distally, proximally, and then proximally again. So this is similar from AO. So 2 hands there and the other assistant hand in the middle. So this will create a 3-point fixation to avoid the elastic recoil or the redisplacement of the fracture, okay? If you do a forearm fracture, it has to be rectangular cast rather than cylindrical. So you do what we call interosseous mold. You use both hands and mold it in the middle. This will keep the interosseous membrane tight to stop it redisplacement, okay? Again, this is FRCS level. If they give you an X-ray with a plaster, what do you think? Again, you look at the reduction, length, alignment, rotation, and also you look for what we call a cast index. So if you divide the lateral width with the AP width, it should be under 0.7. Again, if the cast looks baggy and not well molded, it's not good. But no one will measure it exactly. So you look at like a well molded cast. This is what you want to achieve. And again, in forearm, you correct the deformity, length, translation, rotation. In radial, you restore the radial height, inclination, and tilt. These are the achievements you want to achieve. If it's a physeal fracture, which we'll show you at the end, you need to restore the physis anatomically and correctly to prevent growth disturbance. That's the aim. All we check for the compartment syndrome at the end, and later on, and make sure that the cast stops at the level of the MCP. So they have got full function of the fingers and the digits, so they can bend. So bend at the MCP. The cast doesn't end here, okay? MCP. Right, so now we'll show some x-rays of some clinical stations. Again, these ones, again, I think, I mean, I knew this from before ST3 because I've already done masters before my my ST3, but I think it's a bit FRCS level, but a limping child would come and they might show you the x-ray, because when you see a limping child as an ST3 and you get an x-ray, you might see Paeds. So just to have some information about it. So Paeds, basically, the classic would be a child, a boy, young, between 4 to 8, white background, runs in family. They sometimes call it the Paeds family, so it might be family history is relevant here. From urban areas, low socioeconomic, like Birmingham areas sometimes, okay? Low birth weight. Usually the child will be delayed in his bone age and maybe some relationship to ADHD. That's why maybe more in boys, I don't know. So one knows why it happens. Lots of theories, so don't get too bogged about it. So it can be ischemic theory, can be thrombotic theory, recurrent trauma, viral infection. And Paeds basically is AVN in the femoral head, but in a skeletally immature. It got better prognosis than AVN in adults. Why? Because it's a growing child, high power for remodeling, okay? But it will look like that. So this is not a fracture, it's not an infection, nothing. This is, so if you describe it, for example, you will see this is an X-ray pelvic AP of a skeletally immature child. You can see asymmetry of the femoral head or the proximal femur. What is the asymmetry? There is a loss of height. You see loss of height. There is a collapse. There is irregularity. There is widening of the joint space. You can say there might be some cysts. You can say there might be a crescent sign, for example. There is widening of the physis. There is broadening of the femoral neck. This is all signs of something abnormal here, which is with Paeds. You can also look at there's some extrusion. So there's an extrusion. Again, this is all bit FRCS level, but if you say there is asymmetry and then you put some, signs, you can tell this is good. This is tell them that you know what you're doing. Okay. Can it be bilateral? Yes, but very rare, and usually not synchronous, metasynchronous. If they are bilateral, exactly the same, think of the other differential diagnosis, such as dysplasia, for example. Again, this is quite deep, but metaphyseal dysplasia will be bilaterally symmetrical. Paeds will happen at different stages, never at the same, never exactly the same. Okay, and also remember, it says most likely or looks like or likely to be Paeds disease, but I would like also to exclude other differential diagnosis, which will come to it. Okay. When you ask for an X-ray, they might show this, which looks like a fracture. Again, it's technically a fracture, but it's usually it's not treated as a fracture. This is slipped capital femoral epiphysis. Again, you will say there is asymmetry. There is a dislocation or is displacement of the proximal physis with proximal migration, external rotation of the limb. Sometimes you can see some callus formation or wide or like a bit of irregularities, which mean it might be a chronic rather than acute. But again, it's difficult to find this on X-ray. It might be less subtle than that. So it might be a small slip. This is a massive slip, but it might sometimes be a small slip. Again, this is the opposite. It comes in boys and girls, bigger in weight, so they are obese, and they are older, so teenage, adolescent kind of. They may have renal or endocrine disorder, Down syndrome. For some reason, it happens more in the left hip, and it can be acute, chronic, or acute and chronic. So the history is quite important. Did this happen now? Because it can sometimes be traumatic, and this is completely different. Traumatic is not SOFI, so it's like a femoral head fracture. But most of the time, it not be atraumatic. The child was walking, and then suddenly this happened. And they might have history for weeks before that. So it's mechanical theory. Basically, a fat child, obese child, so increased forces on a susceptible physis. And that's why it happened in adolescence, because rapid growth can cause weakness in the physis, okay? And there's also endocrine theory. So if they have problem with the growth hormone, pituitary hormone, thyroid, so you have to make sure that this is also investigated. Right, how to manage a limping child? Again, they look for comprehensive assessment and safety. So you go by the BOS guidelines for suspected infection. You do a full examination, investigation for a limping child. So what are other differentials? Could it be something else? Yes, septic arthritis, and this is what will ED refer to you. We've got a child query septic arthritis. Most of the time it's not septic arthritis, something else, but you have to exclude it first. Can be transient synovitis, diagnosis of exclusion. Osteomyelitis, again, proximal femur osteomyelitis would present as similar to this. Perthes disease, SUFI or SCEFI. DDH, very rare. I mean, in Egypt, yes, you will find limping child 5 years old and he's got a neglected DDH. But here, DDH would be this, unless there are some immigrants coming here and not through the healthcare system, but very rare. I mean, I would rather not to say it at the beginning unless you've said everything and I said, oh, could it be something else? Also, DDH is painless. It's a painless limb. It shouldn't cause pain. And again, traumatic injuries, like if usually boys usually playing sports, rugby, football, so adductor strains, AIIS, so inferior iliac spine avulsion, pelvic fractures, femur fractures, again, this has to be excluded. But if they say atraumatic, usually then you don't say, oh, could it be trauma? Yeah, I mean, if they say atraumatic, don't just try to irritate the examiners. And again, remember, both for infection. Good points if you can mention Cocker's criteria because you are looking for them, but they've got a name, so you can say. So non-weight bearing, this is 1 point. And non-weight bearing mean as if they cannot even get out of bed, even hobbling on a crutches. They cannot, like a fracture, like neck of femur patient. They can't get out of bed. But if he can walk with crutches, even if he's not putting his foot to the floor, this is still weight bearing. Fever above 38.5, not 37.8 and not 38.5. White cell count above 12, ESR 40 or above, and this was additional added after 2001, CRP more than 20. The good thing is if it is 0, so you've got nothing of those, very, very, very unlikely, and this is quite sensitive, it is septic arthritis. And if you've got 4 or 5 of them, even 3, between 3 and 5, it's very, very likely. Could be something else, could be sepsis elsewhere, but it's very likely. The problem comes when it's about 1 or 2. It's not very clear. So you have to have clinical suspicion, okay, and some common sense. But again, if you've got 4 or 3 or more, or you've got 0 at all, that's reassuring, or this is really worrying. You have to be really acting on it. So management for septic arthritis, again, you will start antibiotic, blood cultures, and you take them to theaters. So mark, consent, book him on a trauma list. Speak to your consultant because consultant might want to take him overnight. You don't wait till the next morning, okay? They say ASAP within 24 hours. But again, every second, 1 septic load, 2 the cartilage can get damaged, okay? It's not like a hip replacement infection or knee infection. It's a native joint in a growing child. You have to protect them. Otherwise, they will live with it for the rest of their lives. So in infection in the hip, you don't go for an MRI, no ultrasound. If you got all signs positive and a child has got painful hip, you probably want to speak to the consultant. He might still request an urgent ultrasound, or you might say, I will aspirate the hip in theaters before I open it, which is a common practice. You put a needle under X-ray guidance and you take a sample. If pus comes out, you open it. Some say, I mean, it can get quite topical if everything is positive and you take it and there's no pus coming out, will you still open it or not? Again, this is sometimes can happen in practice. You might say, I would discuss with a colleague or consultant decision. But I think this is an FRCS, maybe consultant level interview. But basically, you say these children need to be escalated and taken to theaters. Okay, but just to be aware of, things can be done like aspiration, like an urgent ultrasound overnight. MRI will never happen overnight in most places. Okay. If it's SCEFI or SUFI, Perthes, or neglected DDH, again, this has to be discussed with a tertiary referral center and a specialist pediatric hip surgeon. They are not urgent. They can be admitted if needed, if they're in severe pain or need some pain relief and physio. No urgent intervention, so you not put them on the trauma list, except SCEFI or SUFI if it's acute. It may need, however, this is controversial. There are some algorithms say you do it within 24 hours. Some algorithms say you put them in traction for a week or 2 to convert them to subacute, and then you do it. So again, I don't think they will ask about this controversy, but there is no urgency in that. But they have to have a plan. You don't just discharge the patient. These patients should be followed and this in a specific clinic or referred to a tertiary center, okay? But you can admit them for pain relief and physio. Transient synovitis, again, only if you exclude every other possible scenario, only by exclusion. So everything is normal. Usually it's the children middle, like between 4 and 8. So septic arthritis usually in younger, osteomyelitis a bit older, but yeah, common is between 4 and 8. So be very cautious in very young, so under the age of 2, and the very old above the age of 10, to say it's a transient synovitis. But between 4 and 8, if everything is normal, looks normal, it can still be transient synovitis. Maybe a history of viral infection, some prodromal symptoms, but it's not always present. They may have some CRP elevated, might have some white cell elevated, but clinically they will look like a very well child. Like the mom gave him paracetamol and he's running in ED. So that's reassuring. Okay, but you need to make sure that you've execute everything, and then remember safety net advice. Even if it's transient, you give them even a phone call at least a week later to check that everything is still fine. Right, so coming to the last few slides now. So this is some more x-rays. So if you see this, it's a buccal fracture, a torus fracture, a green stick fracture. Again, if they give you one x-ray, it might not be visible, so always ask for 2 views. And again, this is quite easy fracture. Reassurance. Remember, there is a trial called the FORCE trial by Danbury. They randomized lots of children. They give them just a bandage or a sling versus a splint versus a cast. And there's no difference at 6 weeks in either pain or comfort. Basically, you manage parents. If you tell parents, I'm going to put a cast, they say, oh, no cast, then you put a bandage. Or you put a bandage, no, you put a cast. So basically, you manage the parents. But again, have a thing in your mind and say, okay, I will manage this by, again, neurovascular examination, examine everything, history, but then you can put them in a removable splint and then follow up, or sometimes phone follow-up or patient-initiated follow-up. They don't need specific follow-up, okay? Even if you leave them in a bandage or a sling, it's all fine. This is the x-ray they will see. Again, you see this x-ray, so 2 views, skeletal immature, displaced mid-shaft, both bones, transverse fractures. Again, you will manage according to both guidance for forearm, so need to be assessed. Neurovascular status, which is individual nerves, capillary fill, radial pulse, and then you will examine the rest of the limb systemically for other injuries. It might be falling from a monkey bar, for example, and then you have now to look for head injury, and maybe you can say ATLS. So just be careful and be situationally aware, because lots of children can just be jumping on a trampoline, maybe falling from a monkey bar, okay? Maybe falling off a bike at some speed. So yeah, so make sure so assuming it's an isolated, neurovascularly intact, and then you will deal with it according to the post guidance, which is, yeah, you take consent, you give adequate pain relief, and then you reduce it. And you can mention how would you reduce it. You mention what is the quality criteria, so restoration of length, rotation, alignment, the cast is rectangular, interosseous molding, so all of those things. Other fracture that can come similar to this, it might not be very well obvious here. You can see that like a corner, looks like something, so always ask for a second view. That's a slipped physis, distal radius. Can be even worse here in the femur, slipped physis. And again, these fractures usually, again, this can be reduced. I mean, at distal radius, you can do it in ED. Usually femur is difficult, so this will need to be taken to theaters. And again, you worry about the popliteal vessels here, so you have to mention again neurovascular examination, looking for the dorsalis pedis, posterior interosseous, inform the consultant. Again, with any slipped physis, it has to be reduced, accurate, early, so you don't wait for 24 hours. If you can do it within 6 hours, similar to dislocation, ideal. And again, avoid forcible reduction. So you have 1 attempt, 2 attempts, and then if you can't, then you have to do something else. Either open it, give GA, take them to theater, but multiple recurrent forcible reduction can damage the physis. And if when you fix it, you try to spare the physis if possible, like putting screws across, but most of the times you can't spare the physis. You have to go through the physis, and it's fine. It's not going to damage the physis. You go with a smooth spin, smooth, without threads, low speed to avoid the heat, and you try to do it somebody experienced it, so you avoid going with the K-wires 100 times. So you damage the physis. So single entry, smooth pin, low speed, it's fine. You can get away without damaging the physis. This is not in the, I'm not sure if this can come in the exam, but they might show you a femur fracture in a child. Again, if you can see most of the child in one film, this means this child is quite young, usually under the age of 2, non-walker, maybe up to 2 years. So just be aware that this can come in a very young children. And if it comes under 2, you need to worry about, could it be a child abuse? Could it be a non-accidental injury? Again, I'm not sure if I did this for my ST3, but just be aware of what we call battered child syndrome, non-accidental injury. Just be aware of things that can be done. They usually need to be admitted under Paeds and ortho, skeletal survey, social services, take history, etc. So you can look up things. It's an ortho bulletin and on all sources. You can look at what does non-accidental injury mean. But if the orthopedic management is very easy, because this femur, if you leave 2 ends of femur in one room, it will heal. So it's not a problem and it will remodel. So if a very young child, 6 months, you can put Pavlik harness like the DDHs. If a child with under 2 years, you can do spica cast, 1.5 leg. They won't ask you how to do it. If you ask you, I just try to make something up, but I don't think it's within the ST3 level. You can put traction, different types of traction, gallo traction, balanced traction. This one has to be a young child under the age of 2, maybe 18 months. So you can lift the bum up. The bum has to be up the bed. And it has to be under 10 kilos. Otherwise, they get problems, sciatic nerve and femoral nerve injuries by this kind of traction. It does look torturing the children, but it happens in hospital here. If you go to a children's hospital, you will find lots of kids in traction like that and in spikers. So it's not obsolete. It's still the main line of treatment. Don't jump to surgical management like some people do. That's the key thing. Most of the femur fractures can be treated non-operatively. Operatively, you can use elastic nails. You can use submuscular plates. Use this above the age of 5. So beyond the age of 5, so school children, beyond the reception year 1, year 2, yes, you can use them. Or if the child is heavy, for example, you can't use the wire. So this, for example, there's a limit of 50 kilos. Beyond 50 kilos, you have to use plates. And also it has to be length stable fracture. If it's comminuted like that, the elastic titanium nails or Nancy nails is not going to hold. Okay, but again, don't rush to surgical management. Most of them can be managed operatively. And don't forget about the non-accidental injuries. Again, thank you very much. I hope I didn't go much above time. Thank you. Any questions or now at the end?
Yeah, that's great as always. So I can't comment more, to be honest. And I think that's the same from all the candidates. They are very, very happy. I think you covered everything in pediatric, so they don't need to add any more.
There is one question about Chinese trap in ED. Yes, if you find them, use them. I've never used them, maybe used them once, and it was in theaters. So I used it in theaters. And the time I used it was for the perileonate dislocation because it needs sustained traction. You can use it for supracondylar if you need, but in ED, usually you just pull it. Usually it reduces after like few seconds of reduction. So, but yes, I mean, if a child, for example, is presenting with a massive swelling, maybe delayed, yeah, you can use Chinese trap for reduction. I mean, but if you mention them, you should have used them. So they may ask you about what Chinese trap have you used them before, but most people have not used them. So, yani, my advice: don't dig a hole for yourself unless you're very confident doing this.
Any more question, guys, in the Paeds before we move on? That's good. So, guys, we have 2 options. I think just very, very short break to do prayers, and then we carry on. So, 1:15 breakout rooms will be ready, and we'll be going to the mock. Mohammed, if you can send me the presentation on WhatsApp so I can keep it on the group, if you don't mind.